Uh, Good afternoon from UK and welcome to everyone from around the world. We have an amazing lineup of eminent neurosurgeons covering this topic that's always is both easy and challenging in both times, and it's a condition where if you do take it out, if you manage to treat it, then it's obviously an excellent prognosis. And here today we have not only eminent speakers, we have also have illustrious chairs, and also in the audience we have got very senior neurosurgeons from around the world. So the first speaker is going to be Dr. Edward Monaco. He's attending neurosurgeon at Geisinger in Danville, Central Pennsylvania. He had done his medical school in State University of New York in Syracuse, and then his residency in the famed Pittsburgh department, where he worked along with Dr. Lunsford, and I'm sure with Dr. Kondiziolka as one of the attendings in the pioneering radio surgery unit. He's now moved to Geisinger, and it's a real honor and privilege to have him as our speaker for radio surgery and to open this meeting. Thank you, Dr. Monaco.
Well, thank you for that nice introduction. I really appreciate the opportunity. Just confirm that you are seeing my screen.
Yep.
Okay.
We can see it clearly.
Excellent. So I was asked today to speak on the role of radiosurgery for cavernomas, and it is a real honor. I would argue strenuously that I'm the least eminent of the distinguished presenters and faculty here, and I have to give a lot of credit for this work to Dave Lunsford and Doug Konziolka, Ajay Naranjan, John Flickinger, and the group I was able to be a part of while I trained at Pittsburgh, did a radiosurgery fellowship at Pittsburgh, and stayed on as the faculty for a handful of years. Indeed, I relocated to central Pennsylvania, needed a little bit of a refresh, and I'm happy to report that things are pretty great here at Geisinger. So I have no disclosures to report today. And I'll do a little bit of introduction. Cavernous malformations are an increasingly recognized and identified pathological entity. And with that increasing recognition, it's clear that these lesions have diverse clinical presentations. And that's just like any other neurological condition because of the anatomy of where a cavernous malformation can present. And unfortunately, for a good proportion of patients, these lesions are often found in high-risk brain locations. Now, one of the most challenging and vexing problems with understanding cavernous malformations and selecting optimum treatment strategies for our patients is there seems to be quite a variable hemorrhage risk for these lesions. And I'll talk more about that as we go, and I'm sure our other distinguished presenters will as well. But a lot of this likely has to do with where the lesion is located and how sensitive those anatomic or functional areas are to disruption by even a very small hemorrhage or change in size of a lesion. One of the challenges that I'll also talk about with regard to radiosurgery is that there's maybe no reliable way to determine the response to the intervention based on our typical imaging strategies. So we know cavernous malformations are one of the 5 major vascular malformations. They comprise, anywhere from 5 to 15% of these malformations. In general, it's a fairly rare problem. When I would give talks like this in Pittsburgh in the radiosurgery course, we would have radiation oncologists and neurosurgeons and sometimes skull-base otologists. And for radiation oncologists, maybe they never see this problem unless they're at a radiosurgery center. A good proportion of patients have more than one lesion, and it has a tendency to be familial, and it's well known, and I'm not going to get into the genetics of the various familial syndromes associated with multiple cavernous malformations, but that is something that is well recognized, especially here in the States and in the Southwest. One of the very challenging problems in trying to understand how to treat patients, and I know it'll be discussed by others as well, is that cavernous malformations seem to be dynamic. They can spring up out of the blue, they can regress. There are things that cause them. For instance, you'll see patients who have had high doses of fractionated radiation therapy, and even case reports with radiosurgery. So we know that radiation can cause cavernous malformations, but they're dynamic. So it becomes a challenge, going back to my mentioning of their hemorrhage risk and how they behave, to observe these or decide how to treat them. They tend to be equal in terms of their incidence and prevalence amongst men and women. They can present at any time in life. In general, the incidence of cavernous malformations is about 4 times or more higher in adults than in children. And this is an important thing to think about, again, when trying to discern hemorrhage risks and the natural history of these, is that when we make decisions about what is the risk in these patients, are we making determinations based on the assumption that these lesions have been around for someone's entire life, or is this something that happened de novo? And I would be surprised if we have a strong answer for that question. They can be distributed anywhere in the neuraxis, as expected, with the amount of territory supratentorially. Many of them present in that location, and about 20% infertinatorially. And we can divide these, and they're often divided in superficial and deep locations. And so they can present anywhere, and in very highly functional areas, brainstem, basal ganglia, thalamus, and they can be lobar. So I think, to me, this is the key slide in the whole talk about cavernous malformations. And the big issue here is understanding the natural history. And I think what we've done in this field is really work hard to try to extrapolate from studies that have evaluated this in many different ways, retrospectively, attempts prospectively, studies that come from folks with different backgrounds, neurologists, neurosurgeons. And so there's a lot of biases, and there are intrinsic biases to the data that I'm going to present here. But the most important thing is understanding the hemorrhage risk and how we define this. And I find it fascinating when I review the literature, and even how we've talked about it in Pittsburgh, is understanding what are the important hemorrhages to think about. And those are really clinical hemorrhages or symptomatic hemorrhages. When you look at these lesions on imaging, there's often a hemosiderin ring, and there are different hypotheses about that. Some think that there's some leakage of erythrocytes that's not really a hemorrhage that results in hemosiderin, or these could be subclinical hemorrhages where patients don't have symptoms. But I would say the most important thing to understand in these patients are really symptomatic hemorrhages, and these are ones that I would define, and many have defined, as a new neurological deficit with a corresponding imaging abnormality that suggests that there's new blood. Now, there can be asymptomatic or subclinical hemorrhages where there's convincing evidence of new blood, and those are also important to know about. So this leads to some important clinical questions, and we'll talk a little bit about this later as I go. It seems that some people have a higher bleeding risk, and I'm not sure that we understand why. I think that I hypothesize and argue, and I don't see this a lot in the literature, that Hemorrhage risk in certain areas is determined to be high because this is highly functional territory. And we don't truly know what some of the asymptomatic hemorrhages, we can't count them or calculate them or observe them much of the time. Based on these difficult challenges in understanding the natural history, we have to think about how we treat people. And the options include observation and some very distinguished senior neurosurgeons with a great deal of experience are going to talk to us about surgical resection of these and management of cavernous malformations later. And then, radiosurgery has come onto the scene and become an alternative, and I would say for select patients. And that's really the critical thing, and I'll explore that. I'm not going to spend much time on seizure management. Although I do a fair bit of radiosurgery, I am an open surgeon as well and do a lot of open surgery. And so I'm not sure that seizure management is something that we should spend a lot of time on when surgically accessible seizure-causing lesions would be removed just like any other seizure-causing lesion. But there are data on this, and that can be discussed. So we want to know what's the natural history and what factors can just help us to understand this. One of the challenges, and I cite this paper here out of Turkey, is how do we calculate this? And there seems to be an endless way to calculate, what hemorrhage risk is. And here are some examples in this one paper, the discussion of hemorrhage risk. If you perform this retrospective pre-treatment calculation in this radiosurgery study, then you count the first hemorrhage and all subsequent hemorrhages over the number of patient years. And on that basis, you discern an annual hemorrhage risk of 44%. And that basically is from the time of the first hemorrhage. It's not a time from birth or making the assumption that that these lesions are present forever. The second calculation is the first hemorrhage time is 0. So you exclude that first hemorrhage. And in this paper, if you use that calculation, this would basically be a rebleeding rate, 63 hemorrhages over 413 patient years for a calculation of 15.3%. And then another calculation is this congenital calculation, which would take the time from birth and the number of hemorrhages that are present, and you would get a 2.2% annual hemorrhage risk. So you can see that depending on how you make this calculation, there are differences in how you would interpret your data. And so a number of people, and these are older data that I talk about, a number of people have done these studies to try to discern the natural history. And you can see here that the annual hemorrhage rate, depending on whether it's calculated from birth or from the time of first hemorrhage, is in general low, but it's variable and has been reported to be as high in patients who have had a bleeding event in these series as over 20%. So my mentor and I would say friend, Doug Kanzioka, looked into this in 1995, entering patients into a prospective database for patients that were referred to the University of Pittsburgh to try to understand the natural history. And this is just one attempt. And in 122 patients, half of them had no clinical previous hemorrhage, and half of them had previous hemorrhages, with most of those patients having only one symptomatic hemorrhage. We can see that these lesions are about half of them in deep structures and half or so hemispheric. And when you look at the prospective hemorrhage rate that was observed in the follow-up period, the patients who had no previous symptomatic hemorrhage, those lesions seem to be quite benign, with an annual risk of hemorrhage of about 0.6%. However, in patients who had a prior hemorrhage, there were eight bleeds in the follow-up period with an annual hemorrhage risk of about 4.5% or so. The overall risk in the entire group was about 2.6% per year. And interestingly, Dr. Kanzioka used the retrospective hemorrhage risk, which I will call the congenital calculation of these patients, and the overall risk was only 1.3% from the time of birth to to the time of follow-up. So there is likely a natural history of these. Will we ever fully calculate it? I think it's going to be very challenging, but I think one of the things that many folks can agree on is that lesions that seem to hemorrhage or present with hemorrhage, they have a tendency to create or result in more symptomatic hemorrhages. And depending on how you calculate this, again, for a very select group of patients that present to a multidisciplinary tertiary care center who have multiple previous hemorrhages in challenging areas, some have calculated the annual hemorrhage rate of upwards of 30% or more. So some other groups who've looked at this, Porter et al., 110 patients with follow-up, they describe a 4.2% annual event rate. And for deep-seated lesions, upwards of a 10.6% per year rate. And one of the important factors and one of the challenges for folks who are opting to treat these and sometimes suggest people to be very aggressive up front is the fact that only a third of patients in this group had complete resolution of their deficit. So in important functional areas, a hemorrhage can be devastating and patients don't always return to normal. So I sprinkled in some cases from my time at Pittsburgh or from our experience in Pittsburgh. And this is an example of an incidentaloma. And I will mention here, and I'm sure everyone in the audience knows that cavernous malformations will often present with an associated developmental venous anomaly. And this is a patient here with combined malformation with a cavernous malformation and a sizable developmental venous anomaly. This was found incidentally, and I think everyone would agree that a normal patient with an incidentally discovered lesion, that observation is a very reasonable and appropriate strategy. I'll just throw it out there and say that's what I would want. And there's a rationale for observation always, and there should be a rationale for observation in everything we do in neurosurgery. And that rationale is based in part on the natural history, or mostly on the natural history of asymptomatic malformations, based on what we do think we know about natural history, is very favorable. They're in general low risk. The risks of treatment can be higher than the risk of the lesion. And we know as neurosurgeons and evaluating, studies like Aruba, which has been very controversial, that there are risks to our treatments, and sometimes we overlook those risks in an effort to try to treat people. And we have to make this careful calculation, and it can be challenging to extrapolate data from experienced centers over the wide spectrum of neurosurgery that's practiced. It's important to acknowledge you can't improve a normal patient. And another factor here is that in general, these, many of these can continue to have low risk even after one symptomatic hemorrhage. So what should we do? Radiosurgery, microsurgery, when we're thinking of treatment, and when is treatment indicated? Should we do it when there's no symptomatic hemorrhage, when there's one bleeding event, two bleeding events? Again, I mentioned seizure control, either with no bleeding, although there's good data to suggest that seizures are often associated with the hemorrhage. And one of the questions we have to ask ourselves always is patient age and medical comorbidities. Do they allow for any of the various treatments? So the question we should be trying to ask ourselves, or the statement we should be making whenever we're treating any patient with any problem, is when the management risks are less than that projected by the natural history. So when we decide on treatment, location matters. And I know that my distinguished senior presenters after me will talk about this. Intraparenchymal lesions versus lesions that are on the surface or exophytic. Does the hemorrhage create a surgical corridor? And what's the extent of a patient's deficit? If they have a hemorrhage and they have a fixed deficit, are you likely to cause a further deficit with surgery? So one thing I would emphasize when discussing these surgical series and such is many of these surgical series are done by extremely senior, very skilled, well-trained neurosurgeons who have a great deal of experience. And so these are what I would say are the best of the best, dealing with very challenging lesions. And this is the Stanford group, 56 patients, and in the best of hands, an excellent complete resection rate that cannot be understated, at 93%, and large systematic review by Brad Gross confirmed this. But there are morbidities, and they are not insignificant. A 30% short-term morbidity rate and a 5% rate of long-term or permanent morbidity. So it's not insignificant. This German group, very senior surgeon. This is an interesting series. There were 36 patients, and only 20 of them only had one hemorrhage. And the suggestion is that resection is the treatment of choice because of the high incidence of morbidity. And in this group, half of patients or so had a new cranial neuropathy. 8% had new motor deficits, and a third had new sensory deficits. And it's an interesting statement here that in the paper that young patients with incidental lesions, but with prior imaging evidence of a bleed, and that I think that's up for debate to some degree, may be suitable for resection. And so I think all of us need to think about how we treat these patients. I know Dr. Spetzler's plan to speak later. This is a paper from the Barrow. Adib Abla is a colleague of mine and a friend from when we interviewed for residency. I worked with his dad in Pittsburgh. And this is a fantastic paper, 300 patients, but a very senior group, a very senior surgeon with a lot of experience. And half of patients had a new or worsened neurological symptom, with a third having permanent deficits and a 30% perioperative complication rate. About 7% of patients had 20 rehemorrhages, 12 required additional surgery. And these are very challenging. These are brainstem cavernous malformations. And the overall risk of rehemorrhage was 2% per year. And interestingly, calculations on pre-treatment hemorrhage risk were as high as 44% or so in this series. So these are the best of the best, doing the best surgery, and especially for lesions that are very challenging in functional areas with what I would argue are not routine approaches taken every day by most neurosurgeons. These are fantastic results. So here's another case that was treated in Pittsburgh. This is a 22-year-old woman with multiple cavernous malformations, and this left frontal lesion and the right panel hemorrhaged, and she had a seizure at that time. In the state of Pennsylvania, if you lose your driver's license, or if you have a seizure and you lose your driver's license, you can't work and drop because you can't drive, and you have to go 6 months seizure-free. And there are a total of 3 lesions, but we know the left frontal lesion hemorrhaged. So what do? Well, I think that's a pretty straightforward. This is very surgically accessible. This is the lesion that presumably caused the seizure. Based on our best evidence, it's resected, no deficit, and the other 2 lesions are observed. So when we're talking about these, we want to, with radial surgery in particular, we know that that with some vascular malformations, in particular arteriovenous vascular malformations, the history is that we know we can follow these lesions with angiograms and MRI scans and show obliteration. But cavernous malformations are not like that. These are angiographically occult, and on MRI scans, they tend to persist because of hemorrhage and such. So there's a lesion there. So can we have protection without complete obliteration? And I'll talk a little bit about that near the end. And then another important question is, what if the natural history of these lesions was never to bleed again? So if you had a bleed or 2 and it was never going to bleed again, if we knew that for sure, maybe we wouldn't do anything. Some people refer to this as clustering events. And I think there are data to support the notion of clustering, but I don't think that explains everything that's happening with these lesions, especially in the context of radiosurgery. So I would say these are indications for cavernous malformation radiosurgery, that we practiced at Pittsburgh, and was really developed and scrutinized and carefully thought out by Dade Lunsford and the rest of the folks in Doug. And in general, we treat patients if they have 2 or more clinically distinct hemorrhage. And I'm going to say these are very select patients where this is not done flippantly on, you know, a right frontal lesion that hemorrhages that is very accessible. They have to have a typical appearance. We've excluded other causes or other vascular malformations. In patients with multiple lesions, you would only treat the active one, and that's the same thing you would do for surgery. And then the last is when resection poses an unacceptable risk. And I will admit that that's a very subjective thought. Different surgeons would say that different things are unresectable versus being resectable. And so that, again, is subjective. And the other thing I would comment here is that in the series that we experienced in Pittsburgh, these are the most challenging patients. 90% had previous deficits, 20% had previous surgery, and they still had hemorrhages with a persistent lesion. So very challenging cases. We know in the early years of radiosurgery, like with radiosurgery for other lesions, you know, we treated patients in a certain way. We selected doses that we thought were appropriate, and a lot of these doses were much higher than are used today. And complication rates, you know, had a tendency to be quite high. Even Bruce Pollack at the Mayo described a complication rate of upwards of 60%, and some of the early work by Steiner as well. And one of the things to think about here is it's not clear always how these lesions present insofar as an association with developmental venous anomalies. We do know that treatment or disruption of a developmental venous anomaly can lead to complications and can lead to devastating complications with radiosurgery and with open surgery. And it's thought that some of this is related to involvement of a developmental venous anomaly. Here's an example of one of the early cases, a challenging surgical lesion. Again, 2 symptomatic hemorrhages, and the patient was treated with radiosurgery. As I discussed with radiosurgery in general over the years, there's been a dose de-escalation, and you can see in the first group of patients that were treated in Pittsburgh that higher doses over larger volumes resulted in adverse radiation effects. And I would argue that over time, and I'll tell you briefly at the end, the way that a number of groups have handled this is by lowering the marginal dose and using small isocenters for planning and planning within the hemosiderin ring, and even some groups specifically avoiding a dose to an associated developmental venous anomaly. So here's another case. This is a patient with a mixed malformation and a notable developmental venous anomaly. This patient was treated after 2 symptomatic hemorrhages. And 1 year post-radiosurgery, this is a good example of there's still a lesion there. The developmental venous anomaly is patent, and the patient hadn't had another hemorrhage. So again, one of the challenges with radiosurgery is that there's no imaging correlate that we can use. It doesn't make sense to say, well, the lesion is smaller or these kinds of things, and they don't necessarily go away. So the important thing to do is to observe symptomatic hemorrhages or evidence of new blood on imaging, and these are measurable endpoints. As with any treatment, in particular radiosurgery, because of potential delayed or long-lasting effects, there has to be, it's a must, an assessment of adverse radiation effects, both with clinical symptoms and imaging. So in our series, and this is some addition of patients from the paper from 2010, 112 patients with a mean age in the late 30s, early 40s. There were a mean number of hemorrhages of 2.5 or so, and this ranged from 1 to 10. And again, there were only 2 patients in this series, and when you look at many of the series, there were only 2 patients with 1 bleed. So these were patients generally who had multiple hemorrhages, and again, almost 90% had a deficit. They were located throughout the brain, mostly in deep-seated structures, and this is the radiosurgical technique. Using multiple isocenters, most of these were generally small in malformation volume. For the entire series, the mean marginal dose was 15.9, but as I said, over time, we've decreased this dosing strategy. And so when we looked at these patients, we performed a pre-radiosurgery. Again, this is a retrospective hemorrhage rate, and we calculated this based on excluding the first hemorrhage. And so the number of hemorrhages in this group over the number of patient years, and these patients with solitary, very challenging lesions that had multiple hemorrhages seem to have a high hemorrhage risk. Post-radiosurgery in the series, upwards of 16 years of follow-up, there were 21 hemorrhages that were observed for about a 4% annual hemorrhage risk in the entire group. Now, if you take a latency period and involve it based on what we know about how radiosurgery works, is that it takes some time. And this is, I would admit, somewhat arbitrary based on what we think about with arteriovenous malformations, but an understanding how radiosurgery works in a delayed fashion, that in the first couple of years after radiosurgery, the risk of hemorrhage is about 9.7% in our study, and it decreased down to about 0.6% after the 2-year mark. So there was a significant decrease in the occurrence of hemorrhage in these patients after radiosurgery. There is morbidity. In the series, about 18 patients had new symptoms. Most of these were at higher doses. There were no major morbidity after 1992 when patients were treated in different ways with lower doses, with higher numbers of isocenters, MRI imaging and such. 8 minor deficits, 7 temporary deficits. And all radiosurgery complications in the series were observed within 1 year of treatment. And this is what an adverse radiation effect would look like. This patient is 6 months post SRS for a deep-seated lesion, and you see that this flare T2 signal abnormality that's associated with neurological deficit. So some argue that the radiosurgical effect is simply clustering, and that these lesions weren't going to bleed anyway, or were likely to bleed less, and that the effect of radiosurgery doesn't explain this. And I think that there's an argument to be made that there is clustering, and Fred Barker's group looked at patients, 141 who were selected for resection or radiation. Interestingly, about 80 or so were treated after only 1 bleed, and there was a 2% monthly bleed rate that patients experienced for the first couple of years, which is still a 24% annual bleed rate. And that only decreased to a 1% per month bleed rate, which is still a 12% annual hemorrhage rate. So these are still quite high. It does suggest that there's some possibility that hemorrhages cluster, and I think that that's a reasonable assumption, but the degree to which they cluster, I don't think anyone can predict and say for sure that they're going to be burnt out and not hemorrhage again. And if you look at our data, the difference between these bar graphs before and after radiosurgery, there may be clustering here, as evidenced by the decrease in the rates of hemorrhage after the initial hemorrhage. But when you compare to time after radiosurgery, I think it's, at least in these data, in this select group of patients, it's hard to say that clustering explains everything. Now, some argue that the mechanisms of radiosurgery, or how we understand how they affect blood vessels and cause obliteration of, for instance, arteriovenous malformations, does not explain how this could work with cavernous malformations. And admittedly, the data we have on this are most often from patients who have failed radiosurgery. And this is our Pittsburgh group again. There were 4 patients who had radiosurgery who suffered rebleeds despite this at varying times. And these patients underwent surgical resection, and we looked at this pathologically. And it's what we can say is there is definitely a pathological response to radiosurgery. Now, these patients, of course, failed, so there's going to be persistent cavernous malformation here, but there's definitely sclerosis and obliteration of vessels, the longer you go. And, really the only way you would know if this worked would be to do autopsy studies in patients who didn't have clinical hemorrhages. And that's, in this day and age, that doesn't happen so much. So I believe 100% in resection, and I think the rationale for resection is very strong. We can be pretty confident that complete resection dramatically reduces, but I think admittedly does not eliminate the risk of rebleeding in most people. It certainly can be curative. Surgery immediately reduces that risk with complete removal, but we know from the surgical series that even with the thought of complete removal, there's evidence that there can still be rehemorrhage because maybe it wasn't completely removed with some microscopic remnant, and these patients should still be followed. Hemorrhage can create a corridor because of the expected deficit, and if those deficits are fixed, maybe we don't have as high a risk with surgery. It avoids future bleeds and future deficits. But we always have to remember, because these are vexing lesions, as they can arise de novo in other parts of the neuraxis, we have to follow these patients. What is the rationale for radiosurgery? Well, we want to decrease the hemorrhage risk, and that decrease in risk should be greater than the risk of potential complications. This is the natural history question. In a very select, again, admittedly with a selection bias of patients referred to a radiosurgical center who have very challenging problems, a fifth of which failed previous surgery, there is a risk reduction in these seemingly high risk patients after from 39% or so to about 0.5%. And that's similar to the natural history of in general benign lesions. The overall morbidity was around 18%, but most of that was minor. The nice thing about radiosurgery is it's easy to treat multiple symptomatic lesions, or easier, and certainly less invasive. And I think it's hard to make an argument that there isn't a pathological response that we see with treatment with radiosurgery. So in conclusion, it's really important to consider all options. In today's age, we have to have a patient-centered approach and present as much data to our patients and make appropriate recommendations that we tailor as well as we can to patients' hopes, wishes, desires, and their pathology. And observation is very important, and I will tell you that I very commonly use observation in patients who seem to be low risk where these lesions are found incidentally, or they've had a bleeding event that's completely resolved and in challenging areas. When you can potentially cure them, that's definitely desirable. There's no one would make an argument that that's not desirable. And surgery is very important. I do open surgery and I treat symptomatic ones that I feel I can reach, or refer to folks who might have more experience doing more challenging things. So surgery is important. Radiosurgery, I think there's evidence in very selected populations, not the entire population of all cavernous malformation patients, but in very challenging groups, that radiosurgery confers a definitive risk reduction, and that benefit seems to be pronounced in a delayed fashion. And I think one of the biggest challenges that all of us need to ask ourselves with this particular lesion is, what is the true natural history? And I think we have a glimpse of this, but no one really knows for sure. Now, if you are going to do radiosurgery, patients should have evidence of more than one bleed. Again, this is this notion of a highly selected group where we're tailoring specific treatments to them and offering them multiple options. Targeting is done within the hemosiderin ring. Patients should be treated with multiple small isocenters, and generally, I would recommend that patients have treatment at centers that have some experience doing this. There's good evidence now, or growing evidence, that lower marginal doses can still achieve stabilization of these lesions and reduce the risk of side effects. And I think there's evidence that and kind of empirical thoughts that avoidance of the DVA makes a lot of sense. If you're going to do radiosurgery, you must commit to following these patients. Just like with open surgery, there could be a delayed risk of, there is a delayed risk of needing something else done because of rehemorrhages. And it's probably best reserved for these highly selected patients where there are deep-seated, felt to be challenging for surgical resection. And again, this can be a subjective determination. So I'll leave you with just the way that I practice, and especially I did it when I was doing radiosurgery with the group in Pittsburgh, and I have treated patients with cavernous malformations with radiosurgery. I have never treated what I thought was surgically accessible, or in general, like a right frontal or a cortical lesion or these kinds of things. I operate on those. Whenever I have discussions with these patients, I suggest that they would see the other folks in my group who would have the expertise to address lesions surgically, and even make the suggestion that folks go visit high volume centers like the group at the Barrow, like the group at Stanford, et cetera, to get a surgical opinion. And I don't think that any of us should be too proud to pursue second opinions or alternative opinions to make decisions. And I tailor my treatment strategy to the patient's disease and their hopes, wishes, desires. And I think it's important to have a multidisciplinary strategy when you're going to include radiosurgery. So I know I went over my time, but I'll leave it at that. And I hope that there can be a lively discussion about this ongoing. And I would thank you very much again. And I look forward to the presentations of my subsequent or eminent speakers. It'll be quite nice. So thank you so much. And I'm happy to entertain questions.
Thank you very much, Dr. Monaco, for that excellent lecture on the role of radiosurgery. And we have got a lot of time to have a really good discussion because, as you know, radiosurgery is done in few places, and those who, when we get patients with cavernoma, there's always that question, whether surgery or radiosurgery. So we have got, as you mentioned, very senior, eminent colleagues in our audience. So I'm just going to ask them to ask you questions and engage you. We have got both senior and operative neurosurgeons as well as radiosurgery neurosurgeons. So it should be a lively discussion. Can I start with Dr. Boop? Dr. Boop, any reflections on Dr. Monaco's lecture and any questions for him? Thank you.
Naren, thank you. My first question, my first question would be, when you treat these lesions with stereotactic radiosurgery, what do you tell the patient in terms of how long it takes for it to start to work? How long do they have before they have any protection?
So, you know, the problem with a lot of follow-up that we do is that, you know, a lot of it is at defined endpoints. For instance, we don't know precisely for arteriovenous malformations when they are obliterated, but we say at certain times because that's where we get angiograms. So I don't quite phrase it like that, but I tell them that again, these are highly selected patients who've had multiple hemorrhages and often have neurological deficits, and many of whom have already tried surgery. Is I just share with them the data from, you know, risk reduction, you know, that we've experienced and other groups have published, even, you know, very similar papers as recently as this year, that after radiosurgery, the risk goes down, you know, over the course of the first couple of years, and the risk after the first 2 years seems to be dramatically lowered. So I don't point to a specific time where they're protected per se, but suggest to them that the risks of hemorrhage go down, and that the risk of hemorrhage is most dramatically reduced after 2 years.
May I ask a question? Ren?
I think you're muted now.
Yeah. Do you hear me?
Oh, yes, I can.
Yes, please, thanks.
Yes. No, I noted thank you, Dr. Monaco, for your beautiful presentation first. And I noted that you say that the high risk, the real risk that needs treatment, most of the time surgical treatment, but as well radiosurgical treatment, after the first hemorrhage. But after the second hemorrhage, because only one hemorrhage. But do you think that a first hemorrhage in a accessible lesion is not just an indication for treatment? Because you mentioned that it's still possible to follow the patient after the first hemorrhage.
And I think that the best way to answer that question is to say that I think you have to tailor that treatment to that specific patient, because I think we can all agree that we don't fully understand the natural history. You know, some people would argue on the basis of the fact that that these hemorrhages can be so devastating. Because they're so devastating and because patients don't always completely recover, that we probably should go after them. And I think the question you have to ask yourself, and I would say on a day-to-day basis, you know, all of us look back at the results of our work or maybe we extrapolate based on the work of other people. You know, I would say I would not compare myself to Mike Lawton in terms of my surgical prowess, in terms of treating brainstem cavernous malformations, but you have to think about if you think you can access that surgically, then yeah, after one hemorrhage, you know, I don't think it's unreasonable if you believe that your morbidity is extremely low. I think with radiosurgery, it makes sense to be cautious. It makes sense to treat, you know, very select patients and not just do this with frequency and not be selective. Like for instance, like a right frontal cortical lesion. I don't think it makes sense, unless that patient absolutely couldn't have general anesthesia, to treat that with radiosurgery. Most of us who are neurosurgeons would say that lesion has to be surgically resected. So it depends. And I don't think because we fully understand the natural history, and none of us can say that we can predict the natural history on a patient by patient basis. I think if you believe that the risks of your treatment are less than the risks of the natural history in that patient, and you have a dialogue and they accept those risks with the hope of treating their problem successfully, I think it's not completely unreasonable. But I would prefer personally to treat patients that have really defined themselves as either surgical treatment failures and high-risk patients who've had multiple hemorrhages.
Oh, yes, of course, there is based on the specific characteristic of the patient, of the lesion, of course. You cannot improve, as you say, a normal patient.
Right,
no?
Right. And that's the challenge. I mean, all of us have even seen deep-seated brainstem, thalamic basal ganglia cavernous malformations in asymptomatic patients. And you think, how is that possible? But you shouldn't ever treat that if the patient is normal. That's why I find certain series or the notion that you would resect a totally asymptomatic lesion, because even if you look at the prospective natural history data from a number of systemic reviews and meta-analyses, you know, for incidental lesions that have not hemorrhaged in the brainstem, the risk is still, you know, not unreasonably low to observe these patients, and the risk of surgery is very real.
Yes,
that's great. Thanks. Thank you very much. I'm going to ask the senior colleagues and then come to a question. Dr. Professor Miguel Arad, do you have questions for Dr. Monaco? Thanks.
Yeah, well, a couple of comments. Thank you very much. First of all, congratulations, very nice presentation, very illustrative about the issue. Well, I have one question. Do you have any different policy regarding the location of the cavernoma? I mean, the potential morbidity of rebleeding is different at the supratentorial region compared with brainstem. Do you have, if I may say, more aggressive policy for treatment if the lesion is inside the brainstem compared with supratentorial?
So that's a really interesting question. And my thought on this, I've never seen published, and I probably should put it out there, because I think we all know the answer to some degree about why, or we think we know the answer about why deep-seated lesions seem to hemorrhage more, but no one ever qualifies that and says, well, the brainstem and the basal ganglia and the thalamus and deep-seated structures are much more functional than the cortex, which is vast. So do we really know that cortical lesions or accessible subcortical lesions in silent areas bleed less than deep-seated? I don't think we know that. I think it's a reasonable alternative hypothesis that they bleed at the same rate. It's just that we pick up these brainstem and deep-seated hemorrhages much more commonly because patients are more symptomatic. So I think that it's challenging to make that statement. But with that being said, I agree with you that in general, we pick up more symptomatic hemorrhages in these areas, and they're more devastating and more concerning to patients. So, you know, my policy with radiosurgery is I really stick to the very strict discussion about patients who have had multiple hemorrhages and high-risk post-surgical patients who have failed, a very select group of patients. I think in patients who have limited or minimal deficits or who have one hemorrhage, I don't think that it necessarily always makes sense. And sometimes you should let these patients potentially cool off. I've seen many patients who have a brainstem hemorrhage and they don't have a clustering and their deficit completely resolves. And if you had gone in, maybe you would have done the wrong thing. It's a very challenging thing, and I don't think anyone can tell you that they definitely know the right answer. And I think you have to have the discussion with the patient. If they have a devastating deficit, the lesion comes to the surface and surgery is much easier, yeah, maybe you go after that because the patient doesn't want it to bleed again. And you can't tell me for sure what the risk is down the road in that one patient, but there is a risk. If the patient bleeds but gets back to normal, I've had that happen many times. I talk to that patient about surgery and radiosurgery, and they say, well, I don't want anything. I only had one event in my whole life. Why would I have a big surgery, and I don't want to deal with any risks of radiosurgery right now? But some patients do. So, when a patient does have a hemorrhage in a deep-seated area that we presume is riskier simply because it's more functional, I think it's time to have a multidisciplinary discussion. If that's not an area I operate, I talk to my skull-based vascular colleagues and I have them have a discussion with the patient about what they believe the risks are. And if the patient wants to proceed to reduce their risk or finds the risk of having another hemorrhage intolerable, then they should have surgery. If they don't want surgery, I don't think radiosurgery is an unreasonable option, but we should do everything we can to reduce the risk. Small isocenters, lower treatment doses, avoiding the developmental venous anomaly, these kinds of things. So it's really, there's no 100% right answer. It's a tailored approach based on the surgeon's abilities, the patient's wishes, hopes, desires, medical comorbidities, the ability to do surgery. But that's a very important question. I know all of us here, think about all of these details when we decide how to proceed with patients.
Thank you very much, because sometimes now we have a patient, young patient with minor hemorrhage, small cavernoma, just right in the center of the pontine region, high risk lesion for resection, small symptoms, solve spontaneously in a very short period of time. But when the patient is asking what about her future, is a lady, you have to say something. And sometimes the patient himself is maybe forcing you to be treated with radiosurgery because could be less aggressive and more effective than wait and see policy or surgery. I do like very much brainstem cavernoma surgery, but sometimes, well, I think we all agree that we have to be very cautious about the indication that is the key issue for successful, let's say, management in brainstem cavernoma. But sometimes in those cases, maybe the patient is forcing you to do something, radiosurgery, why not? And I think that the perception of the patient is quite different from, the information he may receive from a small lesion at the right, frontal lobe, if I may say.
Agreed.
Thanks. Thank you. I'm just going to bring Dr. Jeremy Rowe and then Dr. Spetzler. Dr. Jeremy Rowe is a senior neurosurgeon in Sheffield. He's one of the neurosurgeons who does radiosurgery in the National Stereotactic and Radiosurgery Center in UK. Dr. Rowe, could you please comment, reflect on Dr. Monaco's lecture as well as any points from your perspective? Thank you.
Fine. Can you hear me?
Yes, yeah.
Grand job. I think everything that's been said is very, very reasonable. We've probably evolved in a slightly different way in that virtually all of the cavernomas that we tend to see are brainstem thalamic. So we regard the supratentorial surgical targets as a completely different set of issues. The thing that's really impressed me is that with modern planning and small isocenters, all of the major morbidity that's come after radiosurgery seems to be related from further hemorrhage events. And then that sort of drives you to say, if you've got a brainstem cavernoma and it's bled once, if the major morbidity is from further hemorrhage, are you happy to wait and sit on it if radiosurgery is an option? Because it does seem that radiosurgery confers a benefit, albeit over a period of time. So I think that certainly in the UK, for deep-seated eloquent cavernomas, we've probably become rather more prone to intervention rather than waiting and watching. But again, it's a conversation with the patient, accepting the clinical uncertainty with no radiological endpoint.
Thanks. Thank you very much, Dr. or Mr. Rowe. That's great to know the different approach and the reason. Can I please invite Dr. Spetzler, your thoughts, sir?
Are you ready for my talk or for a comment?
Comment, sir, comment.
Yeah. Well, first of all, I thought that Dr. Monaco gave a very thoughtful presentation. It wasn't one-sided. I think a lot of controversy remains about radiation and cavernous malformations. And when we talk about radiation of very eloquent areas, you've got to remember that there the risk goes up as well. I've seen quite a few complications, and that has to be balanced, as he did, against the risks of surgery or the natural history. And I mean, that's really what these presentations are about. In my own mind, I am still very, very unsure about whether radiosurgery has a place for cavernous malformation, with the one exception of the cavernous malformations that are located within vascular sinuses. So for example, the cavernous malformation in the straight sinus is a lesion that is very, very vascular, and it is very, very responsive to radiosurgery. So in those cases, whether it's in the cavernous sinus or elsewhere, in those cases, I actually think that radiosurgery is the first line of treatment as opposed to surgery. But I thought it was an thoughtful presentation, and I enjoyed listening to it.
Thank you. Thank you very much, Dr. Spetzler. There's a question from Dr. Ted Vergas. He's from the Philippine Radiosurgery Center. His question is essentially that if patients develop cavernoma after treatment for medulloblastoma, and in those patients who develop these iatrogenic cavernomas, would you recommend treating those patients with the radiosurgery, Dr. Monaco?
So again, I think that this requires a tailored approach. It depends on, we all know that these patients who have craniospinal radiation, whole brain radiation therapy are at risk for developing these lesions. I think, we have an experience, or had an experience in Pittsburgh treating radiation-induced meningiomas, for instance. But, if I could tell you that there was a vast experience treating radiation-induced cavernous malformations, I wouldn't be telling you the truth. I think you have to tailor it. If the patient has a surgically accessible lesion that's multiply hemorrhagic, then I think you operate to remove it. I think if the lesion is in a very challenging area and surgery doesn't seem to be a possibility, I don't think that it's unreasonable to treat that with radiosurgery with all the caveats that I described. So it's, again, having that risk-benefit discussion. Is the location allowed? Does the location allow for it? Is surgery possible? Can the patient have general anesthetic? Do they accept the risks of surgery or radiosurgery? I don't think it's unreasonable to treat patients even with a radiation-induced cavernous malformation. But the other thing you have to keep in mind is these people's brains are probably sensitized now to radiation. Could you cause more problems? You can. It's very likely the risks of radiosurgery go up, as we know in patients who have whole brain radiation therapy and we do radiosurgery. We actually decrease the dose meaningfully when we treat them. So I think you have to keep that caveat in mind as well. So it's not black and white, and there's certainly not a vast experience or even a meaningful published experience on treating radiation-induced cavernous malformations with radiosurgery.
Thanks. Thank you very much. If for the want of time, if there are any further questions, I'm sure there are many more questions. Please put it, type it into the chat box, and if Dr. Monaco can then answer, then I'll be grateful. So, Dr. Monaco, thank you very much for that excellent lecture and for that great discussion with the senior colleagues. I hope you will join us.
It was an honor to be able to present. I look forward to our other eminent speakers.
Thank you very much. So now I'm going to invite Dr. Kevin Cockcroft to chair the next lecture. Dr. Cockcroft is professor and interim chair of the Department of Neurosurgery at Penn State, and I am delighted to welcome him, as I'm an adjunct faculty in that department. Dr. Cockcroft is a vascular neurosurgeon, as well as currently the chair of the American Board of Neurological Surgery. Dr. Cockcroft, can I please ask you to introduce and then share Dr. Michael Lawton's lecture? Thank you.
Absolutely. Thanks, Naren. Hope everybody can hear me. Thanks, Naren, for putting on another great symposium. These have been excellent and some great discussion there. So we're going to hear a little bit more about the microsurgical perspective now from Dr. Lawton. So many of you obviously know Dr. Lawton, so he doesn't need much of an introduction, and I certainly can't do justice to all of his accomplishments in a couple of minutes. But as you probably know, Mike Lawton is the president and CEO of the Barrow Neurological Institute in Phoenix, Arizona. He's chair of the Department of Neurosurgery there, and he's the Robert F. Spetzler Chair in Neuroscience there. So Dr. Lawton received his undergraduate degree in biomedical engineering from Brown University and his medical degree from Johns Hopkins. He completed his residency at Barrow, and he also completed a fellowship there in cerebrovascular and skull-based surgery. After several years on the faculty at the University of California, San Francisco, he then returned to the Barrow in 2017, taking over from Dr. Spetzler, where he assumed his current role. Dr. Lawton's expertise, as many of you know, is cerebrovascular disorders, so aneurysms, AVMs, cavernous malformations, as well as skull-based tumors. He's treated more than 5,000 brain aneurysms, almost 1,000 AVMs, and about 1,000 cavernomas, including more than 250 in the brainstem or other highly eloquent areas, which he's going to talk about today. As you know, also, Mike is a prolific writer and educator. He's given scientific and educational talks all over the world. He's published more than 700 peer-reviewed articles, 6 single-author books, and more than 100 textbooks. I've had the pleasure of working with Mike in various national neurosurgical organizations, joined him in a few panels over the years where we've debated microsurgical and endovascular therapies for cerebrovascular disease. And I've also been fortunate to take advantage of his expertise in brainstem cavernomas by referring him patients with these complex lesions. So thanks, Mike. I'm excited to hear what you have to say today, and I think we're all really interested to hear about this challenging topic some more.
Kevin, that was very generous. Thank you. Appreciate that. Naren, congratulations. Another great session here. Let me
thank you, sir.
Let me go ahead and share this and hit my play button and hope that you can see now my title slide. Can you see that?
Yes, we can see it very clearly. Thank you.
Okay, great. Well, it's great to be with you all. It's a little early here in Phoenix, but hopefully I can deliver this and remain awake. My charge was eloquent cavernous malformations. And, you know, I know that other speakers will be touching on brainstem cavernous malformations, but I'll probably focus mainly on that just because I've been devoting the year to many projects on this and wanted to share with you some new stuff and talk about that. So my experience, well over 1,000 of these things. The brainstem numbers are into the 300s now, and we're getting near to 100 on spinal cord cav mal. So been fortunate to really be able to see a lot of these things and get very familiar with their behavior. And I'm just going to try and condense or synthesize my experience with all of these patients into this talk. And by the way, Naren, how long would you like this? Are we talking 45 minutes or a full hour?
You're fine with the time, Dr. Lawton.
Okay.
Thanks.
All right. Well, I'm working on 7 Cavernomas, which is the 4th book in my series. I decided this time to release this as a collection of articles in the Journal of Neurosurgery, some of which have come out. But they started in August. We've got about 6 or 7 in press. And so you'll be seeing these dribble out. And at the end of all of that, they'll be collected in another team of books. So, but one of the big things that I wanted to do was to develop a taxonomy for the surgical approaches. A lot of these eloquent lesions require a tough choice between many different surgical approaches. And I think that's where the difficulty comes. And one way of solving the problem would be to develop some AI or computer algorithm to tell you the answer to those tough questions. Another way would be to really develop a taxonomy that guides you through those decision makings. And that's really what I've tried to do. And I'll share with you some of that as it relates to the brainstem. Then, the next goal is really to advance these tissue sparing approaches that use the subarachnoid spaces rather than the tissue to get you to your target. And that really becomes both an exercise in tough decision-making, but also an exercise in difficult approach execution. But that's what vascular neurosurgeons love to do, is to navigate those spaces. So I'll talk a little bit about that. And then finally, seeing if there are ways that we can apply AI technology to these problems. My metaphor for this book is maps, and I'm going to come back to that later. I want to start with just grading for these. We have grades for many things, most things in neurosurgery. We have them for AVMs, we have them for subarachnoid hemorrhage, we have them for all kinds of stuff. And so why not in this brainstem cavernoma problem? Well, we put this out years ago. This is the brainstem cavernous malformation grading. We felt at the time that we really didn't need a grading system for all cavernous malformations because the supracerebellar decisions were relatively straightforward, but we felt like one in the brainstem would be of some value. So in an analogous way to what we did for AVMs, we put together variables that were predictive, that were statistically based, and found that not only did we get an analogous grading system, but the similar variables popped up. As with AVMs, which looks at size, eloquence, and deep venous drainage, we found that size, crossing the axial midpoint, and a venous anomaly were also part of the predictors for this. The crossing the axial midpoint, when considering a brainstem cavernoma, it's like eloquence. Everything in the brainstem is eloquent, so you can't just give a point for everything. But when they cross the midline and they get to those tracks and pathways that are deeply located in the brainstem, that's really the analogous way of looking at eloquence in the brainstem. The point assignment is a little different. You can see that 2 centimeters was the cutoff for the size, the crossing the axial midpoint, also 0.1, and DVA 0.1. But when it gets to things like age, we weighted the age variable by assigning 2 points for greater than 40 years. And there were only 2 splits, above or below 40. A new variable came into play with hemorrhage, and that has to do with the timing of the hemorrhage, whether it's in the acute phase, 0 to 3 weeks, subacute phase, 3 to 8 weeks, or chronic. And the reason why this turned out to be important was that if you have a cavernous malformation that's recently bled, it's bigger, it's pushed its way to surfaces, and it's also surrounded by a liquefied layer that helps you separate the malformation from the brainstem. The longer that the time goes by, the more that liquid gets reabsorbed, the more scarring you get, and the more adherent the malformation is to the tissue. So that results in a harder extraction, one that's a little less gentle and potentially a little more morbid. And so that is the basis or the rationale for that particular finding. And like all of these grading scales, the grade is based upon the sum total. And so you can put this together and get a number from 0 to 7. And that tells you where you are. The picture on the right just summarizes those different variables pictorially so that hopefully you can remember that. This is the table that came from the original paper on the grading system. And you can see that, we only had 100 or so patients, and it didn't really give us the statistical power to really validate the grading system. So once we did this, we actually then validated it thanks to my move to Phoenix and working with Dr. Spetzler. We had a lot of his data to incorporate to help validate this. And what you can see in this validation paper, which was about, if I remember right, 300 or so patients, there's a good spread of the grades in this bell curve. And they naturally divide into pretty much low grade, intermediate grade, and high grade lesions. So the 0, 1s, and 2s are the low grade, the 3s, 4s, and the 5s are the intermediate grades, and the 6s and the 7s are the high grades. And just as we think about AVMs in terms of the low and high grade or intermediate grade lesions being the ones that we know and select for surgery, we can apply the same logic here. You can see how they spread. And here, most importantly, you can see the outcomes after surgical resection. So in the curve on the right, what I've depicted here is outcome in terms of modified Rankin scale with good or poor, with the dividing line being 2 or less for good outcomes and greater than 2 for poor outcomes. And you can see that as the grade goes up, and as we go from low to intermediate to high grade, we get into a more likely scenario of surgical complication or morbidity. The graph to the right confirms the same, except that the outcomes are relative outcomes, looking at patients pre and at last follow-up, so that we can categorize them as same or improved or worse. And so no matter how you slice the outcome, this grading scale actually helps you to predict reliably and accurately your outcome. So here is just one of these area under the rock curves, again showing a respectable number on the ROC, 0.73 for this this grading scale. So let me take you to a different slide portion. Excuse me for just a second. And I want to talk to you about this taxonomy. So taxonomy is really helpful. And I felt like, I really wanted to dive into this when I moved here. You can see what I call the BNI effect. These are my numbers pre and post Phoenix, and you can see the bump in brainstem cavernous malformations, in particular, that blue line below. I was doing about 15 or so per year when I moved to Phoenix, thanks to Robert's referrals and just being in a place where people recognize us as the place for these. The numbers more than doubled. And so it's been a real opportunity to study these in some great detail. And the question is, should these be resected or observed? And I think that's really where the brainstem grading scale helps you to decide that. That will tell you whether you should operate based upon that, the grading. If it's a low or intermediate grade, the results are good. Those are the ones that I select. If it's a high grade lesion, I have my warning sign. I know not to select those. But the second question, I think, is the one that really vexes people, and that's what microsurgical approach. And there have been some heuristics that are out there, like surface presentation, like the 2-point method, like some other things. But this pathologic taxonomy, I think, is really the answer. And I hope to convince you that this can be a tool that guides your decision making and in the process improves outcomes. So, what we did was we looked at types and subtypes, just as I did for my AVM book. For the cavernous malformations, the way I think about these are types, which are regions of the brain, in this case, the brainstem, where we have midbrain, pons, and medulla. And the subtype, just as with AVMs, is the surface presentation. Does it come to the anterior surface? Does it come to the lateral surface? Does it come to the posterior surface? And so this combination of typing and subtyping gives you a descriptor of the lesion that will then lead you to your approach. And the way that this was put together was based on my experience and Dr. Spetzler's experience over both of our careers. And we put together a database of over 600 patients. We have great data, both clinical and radiographic, on 551 of these. And that was the substrate for that. And let me just show you how this looks. This is one of the beautiful illustrations from our illustration department by Kristen Larson and also Peter Lawrence. You'll see some of his work coming soon. But based upon the anatomy that you see in the center panel, we developed subtypes. And here's the midbrain. And you can see there are 5 subtypes here. There's an interpedicular subtype in teal. There's a peduncular subtype in red. There's a tegmental subtype in orange. There's a quadrigeminal subtype in purple or blue. And then in green is the peri-aqueductal subtype. And based upon where the lesion falls, you can then define this as in the midbrain and one of these 5 subtypes. Here's the pons. The pons has 6 subtypes. And you can see here, going around the horn, in the front, we've got the basilar subtype. In the anterolateral corner, right by the trigeminal nerve, we have the peri-trigeminal subtype. The orange is the middle peduncular subtype. The green is the inferior peduncular subtype, where the inferior cerebellar peduncle is coming up and in. The rhomboidal subtype is in blue. This is the floor of the 4th ventricle above the junction between medulla and pons. And then the yellow, which is ghosted through, is the supraolivary subtype, which is the one that is in that underbelly of the pons that you reach from below. As we move to the medulla, you can see, again, here we have 5 subtypes, and I'll just walk you through those. In the front, anteriorly, we have the pyramidal subtype in teal. In red, on the anterolateral and lateral surface, we have the olivary subtype. In number 3 is the cuneate subtype. This is the posterolateral corner, right by the cuneate nucleus. 4 is the gracile nucleus, where we're below the ventricle, but in the dorsal columns as they finish in the midline. And then 5 is the floor of the 4th ventricle, but here we're below the stria medullaris, where you're in the trigonal portion of the floor. And these represent the 5 medullary subtypes. And so you can see that there's 16 different brainstem subtypes. And these, here's just a summary, just showing you how you'll see these as they come out in the articles. They're color-coded, so all the anterolateral ones are in red, all the lateral ones in orange, the posterior in blue, and you can hopefully get a sense of how these lay out within the territories of the brainstem. And what's nice about these, well, here's some data. This is just some data from the database that we put together, just showing you how they lay out. Some are much more frequently seen clinically than others. For example, you can see in the midbrain, the tegmental malformation was a very commonly operated one because of its location on that posterolateral surface. And in the pons, for example, the middle peduncular one was one of the more commonly operated ones. This has to do not only with their geographic presentation, but also, the eloquence of the tissue around them and the surgical accessibility. So there is a bit of a surgical bias here, but some of these are very common, others are not so common. As an example, the basilar pontine one is, I would say, more common than just 2% here of the pontine lesions, but because of the difficulties in getting there surgically to that spot, we see a much lower surgical frequency. Now, one of the things that really interested me was not only should we be able to identify or subtype these anatomically, but we should also be able to subtype these clinically. In other words, at the bedside, we should be able to almost validate or recognize these syndromes just by our bedside acumen. And so here for the midbrain, what we've done here is to show you the 5 different subtypes: the interpeduncular, the peduncular, tegmental, quadrigeminal, and peri-aqueductal. Those are in the columns, but in the rows you see the various symptoms. You can see how the constellation of symptoms that make up these different syndromes can really identify for you the diagnosis, and also leads you down that decision-making pathway just at the bedside, which I think is the real beauty of this. I can remember as a medical student learning some of these brainstem syndromes for strokes and thinking how interesting this was. But here what we've put together is basically the same constellation of symptoms into these syndromes and paired them with each of these different anatomical or pathological subtypes. And so let me walk you through that. And ultimately the goal is to make your diagnosis, and once you have your diagnosis or your subtype, and then it will lead you to the right surgical approach, which is shown here in this illustration. So for example, the peduncular cavernous malformation is one that's approached best with a trans-sylvian transpeduncular surgical approach, which is shown up here in this purple arrow here from the front. In contrast, the tegmental lesion here on the posterolateral surface is best approached with the supracerebellar infertinatorial lateral approach, this orange arrow here. The midline supracerebellar infertinatorial is for the quadrigeminal lesions in blue, and the periaqueductal up from above, a trans-colossal transchoroidal fissure. So ultimately, what this taxonomy gets you to is your surgical decision for your approach. But back to the clinical syndromes and how this relates to the approach. Here's an example of the interpeduncular midbrain cavernoma. You can see in this particular patient, he's got a Claude syndrome. The Claude syndrome is an ipsilateral oculomotor nerve palsy because it involves the third nerve, and it's a contralateral cerebellar ataxia. So that constellation of symptoms will identify for you the interpeduncular midbrain cavernous malformation. You can look at the MRI to validate this, but you should be able, with these two key findings, know that that's exactly where your lesion is and that you need this interpeduncular orbitozygomatic trans-sylvian approach. So the anatomy is shown in the bottom panels. You can see how it affects the red nucleus. You can see how it affects the outflow tract of the third nerve and the third nerve nucleus and its relationship to the other lesions. And sliding over here to the right, you can see the surgical view. The trans-sylvian approach through an orbitozygomatic craniotomy gets you to this carotid oculomotor triangle. It gets you to the P1 and S1 vessel segments. It gets you into this triangle here where you have the exposure and access to the interpeduncular fossa. And our safe entry zone is shown here. It's the interpeduncular safe entry zone that goes just off midline, but medial to the third nerve exit, root exit site. And you can approach lesions here. We prefer these obviously to be either exophytic or on the surface, but these safe entry zones are your fallback if you find, as we often do, that the lesion is deeper below the surface than it appeared radiographically. Other examples, let me just walk you through these. For the peduncular midbrain cavernous malformation, these patients present with a Weber syndrome. So different from the Claude syndrome in its hemiparesis, this is a little bit more lateral. You also have the oculomotor nerve palsy here from the third nerve, but being in the peduncle, these patients have the hemiparesis rather than the ataxia as the reliable finding. And you can see the tracks shown here, and this clinical constellation defines this particular subtype. Sliding over to the right, you can see that we're working now through a different triangle. It's the same approach. It's the orbitozygomatic trans-sylvian, but instead of the carotid oculomotor triangle, we're now in the oculomotor tentorial triangle over here. Our safe entry zone is our peduncular safe entry zone site. It's the medial third of the peduncle. We can make an incision that's just medial to the corticospinal tract shown in blue here, and we can get to the lesion there. Tegmental, this is, as I showed you earlier from the numbers, this is a common one that we'll see because of its presentation just behind the crus of the peduncle. You can see that nicely in these lower panels here, just how it's on the back side of the crus in front of the quadrigeminal or tectal plate. And we can get there nicely. The patients present with what I call the Luminiscule Syndrome. It's because you have three lemnisci that come together, the medial lemniscus, which accounts for its contralateral hemisensory presentation. You also have the spinothalamic tract, and that accounts for the contralateral pain and temperature loss. And you also have the trigeminal lemniscus, which accounts for the facial loss contralaterally. And you can have hearing impairment as well with the lateral lemniscus as it comes up. This illustration from Kristen really nicely shows how these tracts come together in this place as they've made their decussations down low, they're running up to the thalamic territory, and you can see how they all congregate here behind the crus of the peduncle there and right in this space. So this is the clinical constellation. And as far as the surgery is concerned, a beautiful approach is this retrosigmoid lateral supracerebellar infertinatorial approach. I like to do this in the sitting position so that gravity helps me. You can see the head position here. You can see the opening of this cerebellomesencephalic fissure. The lateral mesencephalic vein defines that sulcus just behind the crus of the peduncle there. That's often used as your safe entry zone. It's also important to point out Ryle's trigone here. It's this triangular space that's below this brachium of the inferior colliculus here, the lateral border of the peduncle here, and then down along the superior cerebellar peduncle. This defines this triangular space, and we usually enter along that anterior border of Ryle's trigone here as a safe entry zone if needed. Landmarks, fourth nerve, the S3 segment of the superior cerebellar artery, and we can be careful here to avoid red nucleus and other tracts here. But this is the tegmental anatomy for this subtype. Quadrigeminal, these patients present with something altogether different. This is a Peri-node syndrome, very familiar to all of us from our patients with hydrocephalus and tectal lesions. But for the brainstem cavernoma that's sitting here between the colliculi, you can see the anatomy here. Its impact on the crossing fibers of the outflow from the visual pathways. And so this explains this particular presentation. You can see the classic light-near dissociation that you can pick up at the bedside, tells you exactly where this lesion is. For these same supracerebellar infertinatorial approach, again, I love the sitting position, can do it comfortably. When I'm seated, the patient's seated, gravity is opening up the natural tissue planes. Here's the infragalenic triangle, the space between the basal vein of Rosenthal, the vertical precentral cerebellar vein, and this little triangle here opens up the space. You can see the triangle on the patient's left, the lesion on the patient's right, and we can get right to this. We also have some safe entry zones in this region, the intercollicular safe entry zone, and both the supra and infracollicular safe entry zones can be used. Got to be careful of the exit of the fourth nerve, and got to be careful not to cross the decussation of the fourth nerve in the midline here at that level. Here's the anatomy of interest. You've got your superior and inferior colliculi. Your aqueduct is deep to those, but you've got some room here if the lesion doesn't present on the surface. Periaqueductal, you might recognize those who've been to the BNI, Mark Shornack. All of these Netter-style drawings are patterned or done with people in our team. These patients present with a Nathnagle syndrome. Nathnagle syndrome is this ipsilateral ocular motor nerve palsy with an ipsilateral ataxia. You can also get a Claude syndrome. It just depends on where on the midbrain level you are. The Nathnagle is the lowerly placed lesion down at the level of the inferior colliculus before the decussation of the dentorubral tract. The Claude syndrome is past the decussation of that tract, so higher up, and it just shifts the ataxia to the other side. So these two syndromes will define this periaqueductal midbrain lesion. And here, a beautiful Peter Lawrence drawing showing you the bifrontal craniotomy, the transcolossal transchoroidal fissure exposure. This is through the ventricle, opening up the choroidal fissure, which enlarges your opening in the foramen Monroe backwards into the roof of the third ventricle and takes you all the way into the third ventricle, where you see the massa intermedia or the interthalamic adhesion. And working back from there, you see the cerebral aqueduct and the cavernous malformation here in that sort of perimeter around the aqueduct. Here, ghosted in, you can see some of that anatomy of the third nerve nucleus, the red nucleus, and these lesions tend to lie right in that funnel leading into the aqueduct down here. So those are some of the midbrain ones. These are the pons. You can see the subtypes to your left. To your right, you see the approaches. For the basilar lesion, I like the pterional craniotomy with a Kawase approach. This takes you in that space underneath the fifth nerve. When you drill out that bone, it takes you to that anterolateral surface of the pons as best as possible for those lesions. The peri-trigeminals, I use a extended retrosigmoid and a trans-cerebellopontine cistern approach. You've got to get through the cistern and then to the level of the fifth nerve, and then the lesion lies medial to that in that sort of anterolateral strip, just medial to that. For lesions lateral to the fifth nerve, or if they're in the central pontine region, the trans-MCP approach is really the way to go. We'll talk about this in some case examples in just a bit, but you can go through that safe entry zone of the MCP and get to these regions in here very cleanly, very nicely with low morbidity and good exposure. In the back, we've got the suboccipital telovelar approach for the infrapeduncular lesions, and for the rhomboid lesions, those are just a straight midline transventricular suboccipital approach. I'll quickly go through these in the interest of time. The basilar pontine lesions present with this either a medial pontine syndrome or the locked-in syndrome, depending on whether it's bilateral or unilateral. These lesions primarily affect the corticospinal tract as it comes down, and patients present with either the contralateral hemiparesis or, for larger lesions, a locked-in syndrome. For the peri-trigeminal pathology, you can see here the syndrome is what we call a peri-trigeminal pontine syndrome. It's the corticospinal tract with a contralateral hemiparesis. You've got an ipsilateral ataxia from the MCP. You have a contralateral hemisensory loss with vibration and fine touch, and you can also affect the spinal thalamic tract with pain and temperature. And you can see the lesions sitting here. These peri-trigeminal ones are medial to the fifth nerve, and they're on the surface, that anterolateral surface, as shown in these illustrations. The approach here shows you the various triangles that you get through the trans-cerebellopontine cistern. You have the supratrigeminal triangle, you have the infratrigeminal triangle, and you have the glossopharyngeocochlear triangle for the lower ones. So various triangles of access for these, and our entry zones are either supra or infratrigeminal. It's a more lateral access point, but it gets you into that zone for resection. Middle peduncular pontine subtypes, these are very common. The retrosigmoid approach is a workhorse. These present with a Marie-Foix syndrome, with your fifth nerve symptoms, your ataxia from the MCP, and involvement of the medial lemniscus with sensory findings as well. Spinal thalamic tract can also be involved. Here it is. The approach is through the interlobular triangle. If you separate or open the petrosal fissure and you separate the superior and inferior lobule of the cerebellum, you open this interlobular triangle, you access the lateralmost point of the peduncle, and you get into the MCP laterally and define a transparenchymal course right to the central pontine region that gets you right there. So this is our interlobular triangle. And by the way, the triangles, that's one of the papers in the 7 Cavernomas series that's in press. You'll see all these triangles laid out in all of their anatomic definition. So it's really helpful to guide you as you make these approaches. The medulla, I'm not going to go through these. I want to get to some case videos to show you these in action, but these are the 5 subtypes. The different approaches are either a midline suboccipital approach that's either transventricular or telovelar, or a more far lateral approach that is either to the olivary region or in front to these pyramidal lesions. Here are the various approaches all spelled out for you for the different levels, and these are the outcomes. But I'd really like to just take you up and show you some examples. So pardon the interruption. Let me go up and get to the video portion here. All right, so let me start with this one. This is one in an eloquent region. This is actually, if you look, it's actually supratentorial, not exactly brainstem, but we'll start here. This is a lesion that you can see really lives in the lateral aspect of the thalamus. And you could look at this lesion and say, well, our 2-point method really doesn't help us much at all here because there's really no surface presentation. But if you look really carefully, there is one point right here at the very lateral gutter of the ambient and quadrigeminal cisterns here, where this comes to the surface. And that's going to be the point that we exploit. Our brainstem Cav-Mal grade is a 3. You can see the points spelled out here. And the approach that we're going to use here is a contralateral supracerebellar transtentorial. So we're going to use this cross-court trajectory, this crossing angle of our approach vector to extend our lateral reach. And also in that sitting position, we can get a little tilt upwards so that we can climb into the thalamic territory here and maximize that angle as well. So here's the sitting patient position. You can see the vector in the right, it crosses the midline and it also climbs into the thalamic region. These approaches require this transtentorial extension. So if you don't cut the tentorium, your instruments are going to hit the incisura as it climbs to the galenic region. So you need to widen that corridor with a cut in the tentorium, and that crossing trajectory really gets you the right angle. So here is our video. This just shows you the patient position. Quick animation to just take you through the skin incision, just a simple linear. The craniotomy is a torcular craniotomy, and you're coming in to this side of the tentorium, and it's often that crossing angle that's so nice in taking you over to the other side. So here now is the view at surgery. What I'd like to do first is go down to the cisterna magna and release CSF down low. With that, the cerebellum starts to drop and sag, and you'll come across some of these tenting veins that are on the surface here, which are easily and safely divided. Here, you can see we're kind of in the midline here, but our lesion is all the way to the side. So we've got to start working our way over. These are some of the veins in the quadrigeminal cistern. Now we're following them out into the ambient cistern. You can see posterior cerebral artery here branching into the calcarine and parieto-occipital branches here. We just follow our arterial landmarks into those cisternal pathways that we talked about. Again, exploiting the natural anatomy here to continue as far as we can. Here's that tentorial incision. We need to keep going lateral to get to this thing. So we make a cut in the incisura here. And just by notching the tentorium, you'll see that that allows us to then start making our way laterally. You see the cross-court angle there. Let me go back there and just show you this again. This is where we start to go contralateral. We're moving over on the outside of the patient to the opposite side to get to the lesion side on the inside. And here I'm just following PCA and Rosenthal around the corner. You can see now I've arrived at the lesion, and we see that little stain on the undersurface of the thalamus here. And you're going to see that just with a small 2 millimeter entry here through our safe entry zone, we get into our hematoma, we get right to the malformation, and our angulation here is perfect. We're right looking up to the malformation there. You can see the capsule. And as with most of these resections, we get inside the capsule. We do an internal debulking of this thing. And as the lesion debulks itself, we can then work the planes and deliver this down and out of the thalamus. So the resection is always less interesting than the approach, but here you can see the malformation coming out in one large piece and the beautiful corridor here that's been opened up. This is that clean gliotic plane that you look for at the end of a resection to make sure that there's no remnant, no little last piece that's hiding in corners. Here's our final view showing the extent of our lateral reach. You can also see that crossing angle. I'll go back to that just to show you how the contralateral exposure really helps you reach that, get to that lateral reach or that lateral angle. So there's our overview, shows you how gravity helps you, shows you how the angles help you, and really a beautiful approach. Here's the post-op showing a good clean resection, and this patient did quite well. So next case to show is this one here. This is going to be a contralateral trans-colossal transchoroidal fissure approach for a midbrain and thalamic lesion. This is nice because, again, using gravity, we can open our natural corridors even wider. There are many ways to get to the thalamus. You can go transchoroidal, you can go subchoroidal. You have options for this one here. You can see that the lesion is not only thalamic, but also reaches down into the midbrain, has some ventriculomegaly, which is helpful here. But for this one, we're going to go with the head or the midline turned horizontally. So you're looking at the interhemispheric fissure with the frontal lobe dropped. This is through the corpus callosum and looking down on foramen of Monroe. You can see the beautiful anatomy here. This is the fornix. Septal vein is up here. The thalamostriate vein is over here. The choroid kind of flips down and defines or shows you the choroidal fissure here. I'm dividing the septal vein, which widens this venous angle. And really the transchoroidal dissection takes foramen of Monroe, which is only about a centimeter or so in size, and expands it to about 2.5 centimeters. And so you've opened this window, you've dropped into the third ventricle. Here, working under the fornix, we finally get to the malformation here. You can see that it comes to that medial thalamic surface. And then, once again, by exploiting the angles, we can pull the malformation from the thalamus and into the midline here, peeling it away from the thalamic tissue. And it's a long and deep breach, but the angle lines up perfectly. And as long as you keep things in line, you can work things free. And in this case, this decompresses nicely. There's some fresh blood there to evacuate. We can start to debulk it now here piecemeal. And then as we get to the end of this thing, you can see it delivers itself down. We get to this end where we've got a clean capsule. This is normal, clean thalamic tissue. The danger spot or the blind spot is over here. Very important to go back and inspect and make sure that's completely clean. That's a nice view of the basilar apex through the floor of the third ventricle. You can see the perforators, the thalamoperforators coming off there. It's one of those beautiful panoramas that you don't get to view every day. So there's our overview, just showing you that anatomy, working down the anterior interhemispheric fissure quite a ways down through. An overview of the back of the ventricle showing, this is just to give you an appreciation of how large the foramen of Monroe widens when you do a good splitting of that choroidal fissure. All right, and here's his postoperative MRI showing a nice clean resection. This is our next case. This is a nice example of a tegmental malformation. It comes to the surface of the midbrain here laterally. Sometimes these lesions aren't clearly defined as just one subtype. This is an example that could be also defined as a peduncular, because it starts in the peduncular region and actually continues on through the tegmental region, so it's both. And there, when you have a lesion like this that presents to essentially be both a mixed subtype of peduncular and a tegmental, it then presents you with two options. You can approach this transsylvian through the peduncle, or you could treat it as a tegmental lesion and approach lateral supracerebellar, which is what we did for this. This is the anatomy for these lesions. You can see basal vein of Rosenthal and precentral cerebellar form this infragalenic triangle. We exploit that triangle and go above either supratrochlear or infratrochlear. And let me show you this case. This was a patient who had a prior surgery for a central neurocytoma. So he had a shunt there, which we were working around. But you can see by going laterally and in that beautiful supracerebellar plane, we can go over the cerebellum. We free all of these corners of the cerebellum and just follow the plane all the way to the quadrigeminal and ambient cisterns here. The tentorial incisura forms a landmark here. I'm looking for the fourth nerve as it comes around the tegmental surface here. You can see the superior cerebellar arteries rolling around here. And here's the fourth nerve. So I'm dissecting this downward. I'm opening up that supratrochlear triangle here. And as we continue on, you can see right here, this beautiful presentation of the lesion to that surface. Now here, once again, I'm cutting the tentorium, just like I showed you for that contralateral approach, making this window a little bit wider. So once we've identified the fourth nerve, we can make this little notch in the tentorium. This widens our window and gives us this upper reach. This allows us to exceed the infertinatorial compartment and get up into the thalamic portions of this lesion. And as you can see here, as we open that, the surface presentation is even more dramatic in this upper attic. There's a nice exophytic portion of the lesion here. You can see these branches off of the PCA that are adherent, but we can sweep those away. And as we do, this exophytic component presents us with a beautiful entry point that doesn't require any parenchymal incisions or tissue violation. And there it is. So you can see the resection proceeds as shown here. There's the vectors, and I'm just going to accelerate through here to the end where this thing comes out nicely. We're able to free these large pieces. I like to remove these in as few pieces as possible because that helps to ensure that you're getting it all. But a beautiful corridor here and a nice clean resection. This is a midbrain. I won't show you this video. It's just an example of the peduncular type. I wanted to show you this one here. This is a lateral pontine cav-mal. And the extended retrosigmoid and the trans-MCP approach really is a workhorse. So I wanted to show you that. This is a beautiful example. It's in the lateral pons. The peduncle provides us with a safe entry corridor. And these are the elements of the technique. Extended retrosigmoid, it needs to be extended because you need to shift your angles, which I'll talk about in just a second. You need to open the petrosal fissure to find that safe entry zone, and then defining the right trajectory is the key. So here's the extended retrosigmoid. You really need the ENT style exposure where you skeletonize the sigmoid, really pull the sinus forward and get as much as every last millimeter of exposure in front of the cerebellum that you can do. Then with that exposure, you can take that sort of tangential approach that you do along the CP angle and tilt it about 30 degrees posteriorly. And as you tilt it posteriorly, your entry gets shifted laterally to this entry zone in the interlobular triangle. So this interlobular triangle depends upon opening up the petrosal fissure. This is the fissure between the superior and inferior semilunar lobules. And so here, nicely shown here, how the superior lobule comes down from above, the inferior lobule comes up from below, and the flocculus lies at their intersection. And this is your petrosal fissure that needs to be opened. And as you open that petrosal fissure, you can see the peduncle running its course all the way lateral. So the flocculus drops, the lobules open here, and this is where we enter. And again, this gets us back to our safe entry zones. This one here is a wonderful safe entry zone that truly is safe. And here's our case example. So the sigmoid's been skeletonized up here. We enter the CP angle in this space. The petrosal fissure runs kind of right in the middle of your screen. And by following these branches of ICA, it's just like splitting the Sylvian fissure. We can separate the lobules. You can descend into that fissure. There's a beautiful venous malformation here at the base. It's enormous, but this is all going to be medial to our entry. So here the branches of ICA travel beyond that. This is just some dissection into the CP angle. You can see the trigeminal root entry zone here, but we're going to be far lateral to that. So here's that large DVA, and our entry site is here. If you just look down the CP angle, you're going to miss or skive the lesion. So you've got to open up this fissure as laterally as possible. So that angle didn't line up for me. I have to go back and open even more lateral, following ICA even further out. And this is where you want to be. This is that interlobular triangle where the middle cerebellar peduncle ends between the semilunar lobules. And this is the entry point you want. And now, if you look carefully, this is how our vector lines up. This is the kind of angle that you want for your approach. And this leads us to the lesion. So now we make our parenchymal plunge here. We do have to go through a centimeter of tissue, and that takes us to the lesion. So that's a little finger of the DVA. We get to our malformation here, and it comes out very nicely. So let me, I'm going to actually jump all the way to my concluding slides here, because I want to leave some time for discussion. I'll just summarize by saying, or summarizing the various approaches here. They're in this beautiful book that Dr. Spetzler, Kalani, and I helped put together. And you can read for yourself a lot of the detail behind this. But just to summarize, each type of lesion presents you with many different subtypes, and each subtype has its own prescribed approach. And I'm really hopeful that you'll find the taxonomy of value as you go through. The key to good surgery here is first, it's about patient selection, finding the right patient to operate. And those are the ones that have hemorrhages and corresponding deficits. Those deficits present as these unique clinical syndromes that you can recognize at the bedside. It takes us back to Oslerian medicine, where I think, the brainstem neurosurgeon should be a real astute bedside clinician by putting together these cranial nerve abnormalities and these neurologic syndromes and getting to your diagnosis even before you go to the radiology reading room. You're looking for lesions that are on the surface or either at the pia or at the ependymum. These are the optimal ones to select, but the ones that are slightly below, you can approach and enter safely through our safe entry zones. There are 21 of these safe entry zones, and you can use those when needed. The resection is intracapsular whenever possible and on block whenever possible. And always with these, there's this fine line between wanting to get all of the lesion out and achieve that complete resection, and then tempering that with surgical morbidity and harming the patient. So that's always the fine line that we walk. And I just would remind you that these, a lot of what I've presented to you is coming out or has come out in the Journal of Neurosurgery. The first of our taxonomy papers was published a month ago on the Midbrain. The Pontine paper comes out in I think 2 weeks, so you'll be able to read and digest some of the details. So with that, I'm going to stop, and hopefully I've left a little time for some questions. Thank you.
Thanks, Mike. That was great. Real nice overview of the microsurgical techniques and the pathways. As usual, some great videos. As I do more and more endovascular, I just am, disappointed in our endovascular videos compared to the microsurgical videos. Some really great stuff. So I think we do have some time.
Advantage that we have now over endovascular.
I wouldn't say that, but so one of the things that sort of comes up, though, you talked a lot about the safe entry zones. Traditionally we thought of brainstem cavernomas, the surface presentation was really key to the ones that got microsurgical treatment. But you talked a lot here about safe entry zones. So what I wonder if you could touch on as we go to some other questions, your decision making for who to operate on. I mean, are there people that you don't operate on these days, or do you think that basically all of these are now accessible in one form or another?
Yeah, I think, Kevin, I think you hit on the two key issues. When to operate, and then are safe entry zones truly safe? So for the first question, yes, there are many cavernous malformations that I don't operate on. I think the Brainstem cavernous malformation grading scale, if you want to use that, will identify the high grade and sometimes the high intermediate grade lesions that will help you recognize. Like Robert's AVM grading scale, sometimes you look at something and you have a gut feeling, but it's not until you break down the numbers and actually walk yourself through the assignment of points that you recognize it as a real treacherous lesion. And so I think that's the value, and that can help you with that first question. One of the papers in our collection will be addressing your point about safe entry zones and are they really safe? And what we did, we took all the patients that we had either pictures or video, and we split them into those that had either surface presentation or exophytic presentation. And we compared those to those that were below the surface, where we actually had to incise tissue and make a transgression. And interestingly, there was no difference in the outcome. So in those two groups, what that tells us is that the safe entry zones that we selected, when we had to use them, were in fact safe. There was no difference in the patient outcome. So I was a skeptic of some of the safe entry zones, but this paper I think will hopefully convince you. There's no doubt that some safe entry zones are safer than others, like the MCP safe entry zone through the middle cerebellar peduncle is the best one that there is. You can go through that almost with impunity. There's a little bit of dysmetria and clumsiness in the first week or two post-op, but patients inevitably will get through that and be fine. That's very different from, for example, the lateral mesencephalic safe entry zone. If you have to go through 3 or 4 millimeters of that safe entry zone on the lateral midbrain, that can be a very devastating entry. So some are different than others. And I think that's just one of those things where when you do this a lot and you get some experience with the patient result and the outcomes long-term, you learn that and it takes time.
Yeah, thanks, Mike. I mean, the experience is really key here. We have a couple of questions in the chat. We can go to those if anybody else doesn't have any questions. One of them was about anything specific you would do with the DVAs, or any comments on how to handle a DVA in relationship to these lesions.
Yeah, well, we've learned from Dr. Spetzler that the DVAs are almost a universal thing with these. If not a frank DVA, you'll find, if not a frank venous malformation with the classic caput medusa, you'll find a DVA, which is just an enlarged vein. And so those are normally, physiologically normal structures that need to be preserved. What I have found is, the ones that have big venous malformations associated with them tend to be a little juicier. Sometimes these are very dry and filled with a lot of old blood or pocketed blood. And the ones that have these robust DVAs tend to have a pretty robust, they can have robust bleeding when you work internally within the capsule. And I think that's part of the reason why I think it came out in our statistics that it was important in the outcome prediction, because it makes the resection a lot more challenging. You're working through active bleeding in many cases when you have these DVAs that supercharge the lesion as you're removing it. When you don't have much of a DVA, they can be very nice and clean and dry. So I think that's the one thing. But to your point, you have to preserve them, because when you don't, you find that they do drain normal territory and you can have a deficit.
Do you find that your non-invasive imaging is useful in this regard, pretty predictive of the behavior?
Yeah, the DVAs show up beautifully. You look at your T1 gadolinium enhanced image, they always light up. So they're fun to spot. And in many cases, when you're debating whether a lesion is a tumor or a CavMal or something else like a thrombosed aneurysm, when you find that DVA, the discussion ends. You know that it's a CavMal.
Right. Good point. Yeah. See, another question was about complications of the posterior interhemispheric approach for these thalamic cavernomas. What sort of complications would you have seen?
For the posterior interhemispheric approach or the posterior supracerebellar?
Well, the comment here is the question is posterior interhemispheric approach for patients with a thalamic cavernoma.
Posterior interhemispheric approach, if you're going between the occipital lobes, you've got to be careful of obviously the torcula and the dural sinuses. You've got to be careful of vein of Galen and its tributaries. I like to do it in a gravity-dependent way. You know, what we've learned from Dr. Spetzler and others is that when you invoke gravity and you take a beautiful fissure like the posterior one and you can throw some gravity effect to widen it up, it really makes the surgery so much more elegant and easy. So I do it that way. And complications have to do with a number of things. You'd be surprised. The most common complication is wound healing. So I showed you a linear incision, and you know, patients postoperatively, some of them are in rehab for 2-3 weeks and they're lying on their incision, and that's right in line with the pressure point, and they have wound breakdown and infection. So we've actually reverted to a U-shaped bipediculated supply, where both occipital pedicles supply your flap. So your healing is better and your incision is not directly in line of your pressure. So I mean, that's actually the most common complication that we get with that approach. And we've solved that problem with a change in the skin incision.
Yeah, interesting. I think a lot of people would think that's sort of counterintuitive, and then that linear incision would be more favorable, but good point about the rehab, Another question was about radiosurgery. When or if you would refer a patient to radiosurgery for a cavernoma?
Yeah, Robert was.
I can't ask about endovascular because we can't do anything for that.
I'll answer it in a word, which is never. I don't refer any for radiosurgery.
All right. Next question was neurophysiological monitoring to find a safe corridor. Do you use that, or do you just do it all based on imaging?
You know what? That's a great question. I monitor all these patients with motors and sensories and cranial nerves, and I feel like I have to because it's the standard of care. But I can tell you that the neurophysiologist will do nothing but ruin your day. When you think you have a great resection and you're doing a wonderful job, at the very end, they're going to tell you as you get near those tracks that something went out. And so it does nothing but tell you you've reached the finish line. It doesn't alter what you're doing. I've come to the opinion that it's almost useless, but we're obligated to do it. I think much more reliable is your anatomical guidance, both intuitively, you know, up here, and stereotactically with your imaging. There's no way I would do a case, particularly a brainstem case, without image guidance, and that's become so vital. And then from there, it's just your knowledge of anatomy, because brain shifts, structures get distorted, and you just have to rely on the anatomy. And that's why we spent a lot of time defining these triangles. We introduced a couple new ones, because if you force yourself to really understand the anatomical borders and boundaries of these spaces, then you don't need neurophysiology. What you are relying on is your decision-making and your recognition interoperatively. And that's really, I think, 90% of the game.
Great, good points. Well, we probably have to move on. Just one other question here is maybe a good for sort of poll the audience. Was a question here of a 19-year-old female patient presents with a deep midbrain pontine cavernoma that's bled once with complete neurological recovery. The only treatment option is observation, which I think it sounds like would be controversial. Should this patient avoid physical exercise? The patient is a personal trainer. Do you tell your patients to avoid physical exercise if they have a cavernoma, or if the cavernoma was bled before?
I get that question almost universally, and the answer is no. I think if you make the decision to observe one of these lesions, and whether that's temporarily till the next hemorrhage or for life, you know, you have to let them return to a normal existence, because there's no proof that exercise or anything that we do increases the hemorrhage risk. So, you know, to say that to a patient, and patients come in all the time telling me that they have been told by their doctor that they shouldn't do exercise, or they shouldn't drink alcohol, or whatever, or shouldn't fly an airplane. You know, that stuff is just so unfounded. And I discourage that kind of recommendation.
Dr.
Yeah,
Spetzler.
I would hardly agree. I wonder if we could, well, go ahead, Naren. So I was going to say, if you could poll your audience here to see what people thought. But
I will try, but I think Dr. Spetzler, do you want to make a comment, sir?
Yes, absolutely. I agree with that completely, but I hope that your audience appreciates that tour de force presentation, the thought that has gone into the avenues, the anatomy, the exposures. I must say, I have incredible pride right now in listening to my follower and my previous resident in that incredible presentation. Very well done, Michael.
Thank you. Thank you.
And I'm happy to give up any of my time for further discussion, because this is really the essence of what it's all about.
Oh, we need to have you as well, Dr. Spetzler. We have got plenty of time for you as well. Thank you. Thank you very much, Dr. Cockcroft. Thank you very much, Dr. Lawton. And it's really been an amazing lecture. It's just a privilege to see that, as Dr. Spetzler said, it's not just the hands, it's just the mind thinking things through and having a overall full package is inspiring. Thank you very much.
Thank you. It's a pleasure to be here, and congrats on another great webinar.
Thank you, sir. Thank you very much.
yeah, I concur. Thanks, Naren. Great job here.
Thank you. Thank you. So for want of a time, so we will now move to the spinal lecture on spinal AVM. It's my distinct pleasure to introduce Professor Francesco Signorelli. He is a professor and chairman of neurosurgery at the University of Bari in Italy. And he trained in Naples. That's where he did his neurosurgery training. And then he did fellowships in my alma mater in Southampton, as well as in London and in Montreal, and then worked as an associate professor in Naples, then moving to the current post of professor and chairman in Bari. Professor Signorelli, thank you very much. Looking forward to your lecture. Thanks.
Oh, hi. Good morning. Can you hear me, Naren?
Yes, absolutely.
Good. Okay. Thank you very much for your invitation. Wow, it is really a privilege to be part of this outstanding panel, and I want really to thank very much the previous and also the subsequent speakers for the profound knowledge you are sharing with us. Really, I'm really happy to be here now. So I want to get into the heart of my topic with a case of a 42-year-old man with a 3 months history of lower limb numbness and 1 week history of walking difficulty, and now is able to walk just with a cane, and he has a urinary retention. The 31st of October of 10 years ago, he was hospitalized and the surgery was scheduled for the 2nd of November. His assessment, his neurological assessment, showed an ASIA D, a Cooper-Epstein grade 2, and Aminoflog 6 score, and the neurological level of injury was at L2. This is the MRI at the moment of the scheduled hospitalization, and the cavernoma, which is between T10 and T11, looks like to peep out on the right surface of the spinal cord. But the November 1st, he had an acute paraplegia. He was scored ASIA A with a sphincter retention, and the neurological level of injury climbed up to T12. On the repeat MRI, which is here, T2 didn't really show any evident modification, but with a gradient echo, maybe we have just a little more extra extra lesional bleeding. So, well, how we managed it, we'll see in a moment. Spinal cord cavernous malformations, like their intracranial counterpart, are vascular tumors, mulberry-like. They are located especially in the thoracic or cervical segments. They account for between 5 and 15% of all spinal vascular malformation, and between 3 and 5% of all CNS cavernous malformations. According to different series, they are between 1 and 10% incidental, while the intracranial counterparts are about in 40% of cases found incidentally. Spinal cord cavernous malformations are more frequent in adults between the 3rd and 4th decade, and they are rarely found below the age of 18. And these sometimes lead to a misdiagnosis in the pediatric population. 15% of spinal cord CMs, but in some series up to 14%, are associated with brain cavernous malformations. 12% of patients, they have a family history, and the male-female ratio is about even. Histopathologically, like for the intracranial CMs, spinal cord malformation have as the distinctive feature the presence of abnormal vessel walls with no or fragmented basal lamina. They have no vascular smooth muscle cells, no astrocytic end feet, and the malformed vessels are arranged back to back without intervening parenchyma. The presence of thrombosis is the sign of a low flow, and we can also find calcifications, hyalinized wall, and the malformation is generally surrounded by fibrosis, astrocytosis, and a rim of hemosiderin, which sometimes may extend in the neuropil, and some authors have associated the presence of hemosiderin in the neuropil with a slow neuro decline. As a clinical picture, we can have an acute onset with a stepwise or a gradual deterioration, or even a rapid decline, which are often associated with an extra lesional hemorrhage. In just more than 50% of cases, patients present with a slow neurodecline, which is associated with several intralesional hemorrhages, but also with capillary proliferation and overall microcirculatory changes. Motor and sensory symptoms are equally frequent. A third of patients may present with pain, even sometimes just pain, and in a fourth of cases, patients have sphincter dysfunctions. What about the annual hemorrhage rate? It's very difficult to assess the annual hemorrhage rate because of the difference in the definition of the hemorrhage according to different series. Generally, the annual hemorrhage rate has been calculated with pooled data of about 2.1%, and it looks to be higher in the pediatric age, up to 8.2%. As we heard by Dr. Monaco, also there's a high difference in the report of annual hemorrhage rate may be due to the fact of some authors assuming the cavernous malformation was present at birth, others count from the first bleeding. But the annual hemorrhage rate looks to be very high, up to 66%. Obviously, the radiological diagnosis is made by MRI. It shows a multi-lobulated lesion with a heterogeneous intensity, because the acute bleeding generally has a low signal in both T1 and T2, while a subacute bleeding, which occurs between 2 and 7 days, for the presence of intracellular metahemoglobin, has a low signal in T1 and a high signal in T2, a low signal in T2 and a high signal in T1. While in the chronic period after 7 days, the presence of extracellular metahemoglobin and of thrombosis gives the lesion a high signal in both T1 and T2, while obviously hemosid ring has a hypo-intense ring on T2. The gradient echo sequences, such as the susceptibility weighted images, are very sensitive for blood, and they may also show us point-like lesions. Another gradient echo sequence, the multi-field fast field echo, is very powerful in showing the blood, but it can also overestimate the extent of both intra and extra-lesional bleeding. Treatment. The treatment is in most cases surgical, and observation is reserved generally for incidental cavernous malformations, even though for large lesions and lesions in the thoracic location, which have been associated with a higher risk of subsequent neurological decline, the surgical indication may be illicit, and also in cases of a central disabilitating neuropathic pain, proposing surgery may be correct. For concern approaches, a large variety of approaches have been proposed, but most lesions may be reached through a posterior approach. One key adjunct to surgery is obviously intraoperative monitoring. For all concern intraoperative monitoring, the somatosensory evoked potentials are very useful, because most cavernomas are reached through the posterior aspect of the spinal cord. Both muscle and spinal motor evoked potentials are triggered by the transcranial stimulation, and for what concerns the D-wave recordings, we need to put an epidural or a subdural catheter below the surgical field. For what concerns the muscle motor evoked potentials, they are polysynaptic. So they are very sensitive to anesthesia and to muscular blockade, and may fade over the hours of surgery. While also they are nonlinear, means that they are disproportionately large in decrements for small reduction of the number of conducting corticospinal axons. And they are unstable. It means that there is a substantial variability between trials of motor evoked potentials. While spinal motor evoked potentials are non-synaptic, and resist anesthesia and muscular blockade. They are also linear, meaning that the amplitudes are proportional to the number of conducting axons at the recorder level, and they are stable because they exhibit no more than 10% of trial-to-trial amplitude variability. So for the spinal maps, the threshold for functional integrity of the corticospinal tract is about 50% of the baseline. Means that even if the muscle maps are lost and we have spinal maps at more than 50% of the baseline, we should expect just a transient motor deficit. So this is obviously the procedure of putting the D-wave electrode just below the field, the surgical field, and these are examples of potential of somatosensory, motor, and D-wave evoked potentials. For all concern the surgical technique, once again, the approach is mostly posterior or through a midline myelotomy over the bulging or the region of discoloration, or for deep-seated lesions through a midline myelotomy. It is useful to use ultrasounds or even ICG video angiography for intraoperative localization. Sometimes it's difficult to interpret US ultrasound images, especially in the acute onset cases, because of the extralesional bleeding. DRES can be used as a posterolateral approach. And even though the anterior approaches have been described for more ventrally located lesions, facetectomy, transpedicular approach with eventually division of and retraction using the dentate ligament for cord rotation generally are adequate for implementing the anterior perspective. So microsurgical dissection. Microsurgical dissection generally uses the surrounding gliotic layer, and the resection, if possible, is done en bloc or piecemeal. Laser and even CUSA have been used to reduce the traction over the nervous tissue. And here I have a very small, short video of the patient. We've seen the MRI. This is the discoloration of the posterior surface of the spinal cord. So incision, evacuation of the bleeding, and working all around inside the gliotic tissue. The evacuation, further evacuation of the hematoma helps us to find the plane, and piecemeal removal of the lesion gives us just a bit more space to find the capsule, and a gentle traction over the capsule helps us to further identify the gliotic plane and to work around really avoiding functional tissue. In this case, we didn't use the D-wave because it was too low, the location of the lesion. And at the end, inspection of the cavity and removal of any hemostatic material to avoid the postoperative swelling of the spinal cord. Results of surgery in terms of extent of resection are satisfactory. Gross total resection is reported in more than 90% of cases, although it is sometimes very difficult to judge the extent of resection, mostly in the early MRI due to artifacts due to the bleeding, previous bleeding. That's why it is very important to carry on with the follow-up MRI to be sure that the resection was complete. Reasons for subtotal partial resection, generally oversight, and mostly in case of cavernomas with an irregular shape. So about this patient, about the patient I showed you, he was operated on in emergency. And even if he was graded Asia 1, Asia A before surgery, at a 1-year follow-up, he regained grade T, Asia, aminoflog 6. And after 10 years, he was further improved with aminoflog score 4, occasional urinary retention, and is now able to walk independently. So it is very important to be prepared and operate in emergency in such cases. For what concern the functional outcome after surgery, in up to 25 to 50, even 50% of cases, patients show an early transient neurodeficit. But at follow-up, more than half have improved compared to the baseline. 40% remain the same, while nearly 10% may show an impairment, which is mostly due to a presence of dysaesthetic pain. About post-laminectomy deformity, up to 14% overall have this kind of complication, surgical complication, while just really a minority of cases require correction. Spinal cord tethering, hypertrophic scarring, they may account for a late impairment, neurological impairment, a late occurring of dysaesthetic pain, dysaesthetic sensations. But one possibly underrated complication is spinal ataxia, which is associated with the posterior midline myelotomy and has been reported in more than 15% of cases. But once again, possibly spinal ataxia is underreported because the presence of sensory motor deficit may distort its true incidence. Timing of surgery and the extent of removal are the most significant prognostic factors. Specifically, surgery carried on within 3 months of clinical onset is associated with a favorable outcome with an odds ratio of 2.11, because probably of reduced CM-related cord damage, or because the dissection is easier for reduced scarring around the cavernous malformation, while surgery within 2 weeks from the clinical onset has been associated with a possible negative outcome maybe for the increased cord vulnerability to manipulation within this short period of time after the onset. Gross total resection also is associated with a favorable outcome with an odd ratio of 3.6, while hemilaminectomy has been associated with a better outcome compared to bilateral laminectomy and laminoplasty. This is quite questionable, I think, but what is looks to be really significant is the fact that an acute or stepwise onset looks to be associated with a better outcome compared to slow progressive onset. And also the presence of motor symptoms looks to be associated with a more favorable outcome compared to sensory symptoms, while it is obvious that a good preoperative motor function is also associated with a better outcome. There is no difference in outcome for superficial lesions compared to deep-seated or even ventral lesions. And also size and spinal level do not seem to be significantly associated with the outcome. For what concern management by observation, observation looks to be associated with a worse outcome in case of observing patient for more than 5 years, while it is important to note that the observation is associated with a better outcome when compared with partial resection. So at the end, my conclusions are that early resection within 3 months from onset should be preferred when surgery is indicated, obviously. Emergent surgery should be selected in case of acute neurological decline, and complete resection should be pursued if feasible, as the outcome for incomplete resection is worse than observation. Customize the surgical approach and the technique, including tailoring the intraoperative monitoring, lead to an optimization of the outcome. That's why these vascular malformations should be centralized in specialized centers. So with this, I think I finished my short presentation. I invite you to my CT, and I'm open to discussion. Thank you, Naren. I hope
Thank you very much, Professor Signorelli. Covered very lucidly the spinal cavernomas, how to approach it, and in terms of neurophysiology and surgery, and in terms of the outcomes. Thank you very much for this lecture. This is a really difficult area because this is more and more, this is far more rare than the brain cavernomas, at least in my practice. I'm going to ask Dr. Mr. Kyrillos. I will just make sure that I will allow people to talk. Mr. Kyrillos, do you have any comments or questions to Professor Signorelli? Mr. Kyrillos is a senior neurosurgeon who used to be at Cambridge, who was one of the he was one of the inspiring neurosurgeons for residents in Cambridge and UK, and now he's in Singapore. Mr. Kyrillos, can you hear us?
Yeah, thank you, Naren, and thank you, Francesco, for such
hi.
Hi, very
How
nice.
are you doing?
Fine. Well, I have one question and one question from the chat. Really, when you mentioned the ventral location does not affect outcome, because it is more demanding to rotate the cord and access them. Do you think that people are reporting the outcome simply as the cases has not deteriorated?
Yeah.
If they operate early? Because if you operate early, you are obscuring your deficit somehow.
Well, about the ventrally located, really, there are a minority of cases, so maybe this is a bias of selection also. But what I think is that choosing the approach, a ventral approach, is somehow more technically demanding. And the thing is, when you operate on cervical or thoracic, also the interpretation of the D wave in the ventral, for a ventral approach is very difficult. I don't know, what I feel is that ventral location can be dealt with very efficiently with a posterolateral approach and exploiting the gentle rotation of the spinal cord using the dental ligament. Obviously, you have to interrupt more than one dental ligament, but I do not think that we need very often another kind of approach.
Thank you. Yeah, thank you for that. This answers one of the questions of the chat who wondered how do you approach the anteriorly located. He was asking, do you split the cord? But obviously, this is not the case. Yeah. And the other question was, if you have to stop the surgery because of your monitoring, reduces and there is still a residual, what is your policy after that?
Well, actually, if you have, first of all, the muscle motor evoked potential are not so reliable. So I would, even if I have a significant reduction of muscle evoked potential, I wouldn't bother. I would obviously stop and irrigate with papaverine and then resume surgery. The problem is if I have a significant reduction of spinal evoked potentials. But also in this case, I would stop, irrigate with papaverine, allow a few minutes or even several minutes of the cord, the microvasculature to resume and then to go on with surgery, because really the most important, one of the most significant prognostic factors is the extent of resection, and dealing with a repeat surgery for a residue of the cavernous malformation in spinal cord is really challenging, and a repeat surgery for residual is really risky. So much effort should be put in anyway achieving a gross total resection, a total resection.
One question appeared in the chat. I don't know if it is still time. Do you refer patients for radiosurgery or radiotherapy?
No, well, actually, I don't have any. That was one of my questions I would like to put. I've never put indications for radiosurgery for spinal cord cavernous malformation. I don't think there is a place for that, but obviously this is my ignorance. Yeah.
And another one appeared, do you operate after the first bleed? Which of course you showed the outcome differs.
Yeah, well, it happened to me to operate in a case like in this case I showed you, in an emergency situation for a very severe new deficit. I think that with a proper microsurgical technique, there is no higher risk in operating in the acute period, but still, that could be just my personal view. I don't think there is any contraindication in operate even in the early post-bleeding period.
And there was a question from Naren Dio. Does increasing the blood pressure?
Yeah, surely.
Yeah.
Surely. I think this is a good point. This is very important. Yeah, to raise the blood pressure. Yeah, surely.
Right. Thank you very much, Francesco. This is to demonstrate that this is not a surgery for the occasional surgeon. You must have experience follow-up so that you can perform such surgery for these delicate lesions. Thank you very much, Francesco. Naren.
Thank you very much, Mr. Kyrillos, and thank you very much, Professor Signorelli, for this fabulous talk. Learned a lot, and as Mr. Kyrillos said, with the margins of errors in spinal cord lesions are very, very, very small, and it's good to have a good large number if you are doing it. Thank you, sir. So I hope you will stay on for the next lectures. So if I may ask, I'm going to introduce Dr. Boop, Dr. Frederick Boop, who's going to chair the next lecture. Dr. Frederick Boop is a neurosurgeon in chief at the famous St. Jude Hospital. He is currently the president of the International Society of Pediatric Neurosurgery, a past president of the American Association of Neurological Surgery, and also he's a co-chair of the American Board of Neurological Surgery. He has been in the forefront of pediatric neurosurgery for now 20 years, and has not only been advancing the treatment of tumors, taking to the next level with his department, but also has been very active in pediatric neurosurgery teaching, both in developed and developing countries. Certainly, he has been a key figure in our Listserv. Dr. Boop, may I please ask you to introduce and chair the talk of Professor Diopujari. Thank you.
Well, thank you, Naren, and I hope that you'll make the recording of this symposium available to neurosurgeons in training around the world. This is just superlative session. Thank you very much. So when I think about cavernous malformations in childhood and the role of the pediatric neurosurgeon, we have to think about the genetic forms of this disease, the familial inherited forms of this disease when we see it present in childhood. And whereas with adults, they may live with the consequences of our therapies for 10 to 20 years. When we treat children with this disease, they have a half century or more to live ahead of them with the consequences of our treatments. Oftentimes, these children are too young to be placed in pin fixation, so that can be challenging when we look at some of these elegant adult positions for approaching these malformations. And you have to remember that these children are going to wake up, they're going to scream, cry, vomit, and then try to climb out of bed. And so dealing with these patients post-operatively can be challenging. Trying to reduce complications. I can tell you, taking care of a 2-year-old with diabetes insipidus can be challenging for any good unit. So there's no one more experienced and more appropriate to give this lecture than my good friend Chandrasekhar Pujari. He's a senior professor in Mumbai, but he is a man of the world who has spent time training not only in India, but in Newcastle, Detroit, Toronto, Miami, and Mainz. He's a world-renowned expert in endoscopic skull-base surgery, and I look forward to his presentation. Chandrasekhar.
Thanks, Rick, for your kind words. And in next few minutes, I would share some experience with children. I think a lot of things about cavernous malformation has already been said, and I would try to concentrate on some of the peculiarities which we find in children and how we deal with them. One of the interesting things which I really find difficult to understand is the new classification of vascular malformations is put the cavernous malformations in the venous malformation category. When you look at the epidemiology, we have all heard about most of the cases, adult cases, and though about 0.5% of the population probably harbors cerebral cavernous malformation in their lifetime, less than half of them may become symptomatic and commonly present beyond third decade. Though about 25% patients are supposed to be below the age of 18 years in most series, in my personal opinion, in the operated patients, I have had about 44 out of 118 patients whom we have operated, the youngest being about 23 months. I have found that below 2 years, there are very few cases reported so far. Location-wise, as bleeding brings them to you very early, brainstem is the most common location in our experience. And there have been patients who are presented with seizures, about 18 of them, and some in other deep locations like basal ganglia. And though conservative approach is usually observed for asymptomatic cavernous malformations, and we have heard some debate on this, I think we will talk about it as we go along. 2 cases reported by these people from United States have probably a child with about 2%, and a general literature review has shown that about 10% of cases are familial, and they have actually shown 85% of cavernous malformation in children being supratentorial, while we found that we have a higher proportion infratentorial. Hemorrhage is more likely to occur in children, even in supratentorial location. That is what is being said in many reports. But I don't think we have enough information to say that. Probably the presentation is equal in terms of seizures and hemorrhage. Other modes of presentation which you see rarely are increasing focal neurological deficit, or occasionally even raised intracranial pressure, as I will show in a couple of cases which presented to us. I think imaging wise, we are all aware that most of these are sort of not round, but some kind of elliptical or either popcorn or hemorrhage. And when they present with first hemorrhage, occasionally they may require an angiogram to demarcate them from arteriovenous malformation. Radiological literature talks about these 4 common varieties, which are acute, classic, popcorn, punctate, which happens mainly in the familial, and some of them are chronic, where you see multiple hemorrhages. This patient is virtually occupying the whole brainstem. But we have seen some interesting cases with cystic malformation and giant, large lesions presenting more like tumors rather than an acute presentation. And I have this one odd patient, an 18-year-old girl who actually was complaining only of headache, was referred to us as a cavernoma, but a CT scan showed that the whole lesion was ossified. Was it ossified cavernoma or some other lesion is difficult to determine. I think the first classification for these lesions came from Barrow, and this has been very often quoted and is used when we make some of the treatment decisions, that the morphology of these lesions on MRI probably determines what is the possibility of their bleeding. Grade 2, type 2 being the most common ones which bleed and which have a more tendency to bleed. Does it happen the same way in children? I think this paper from Necker, I think Frederico has written this about 199 MR examination in children who had a long-term follow-up, and out of 355 cavernous malformation in 70 children. And they have shown that the mean annual hemorrhage rate and mean hemorrhage-free interval for cavernous malformation, with or without signs of previous bleeding or blood degradation product is virtually same as in adults, and probably the Zabromsky classification, it is still possible to predict hemorrhage based on this classification. There is also a talk, and we have heard some cases shown by Dr. Lawton, that though the individual cavernous malformation and DVA have benign course, when they coexist, there is probably a higher hemorrhagic risk in these patients, especially in children. And this is a recent study which tries to tell us the same message, that probably when they are together, there is a greater chance of hemorrhage occurring. This is one of the patients presented with a typical cavernous angioma. You can see popcorn. And earlier we used to when you find a vein like this, you used to do DSA to confirm. However, it seems a very classical radiological feature now, and it is probably not necessary. And unless they are very symptomatic or they have bled more than once, we do not really operate on such patients. This is one of the angiograms done several years ago for showing the DVA in this patient. I think the decision to treat a patient by surgery becomes very easy when you have a malformation in a area which can be safely resected. And this patient presented with seizures for almost a year, very frequent seizures, not responding well to medical therapy, and had this cavernous angioma in the medial temporal lobe in hippocampus, and it was an easy decision to take it out completely. And this patient has been seizure-free since then. And the main consideration in these is that should you operate them early, or should you allow them to become intractable to decide about surgery? And most of the papers and meta-analysis show you that gross total resection and early operative intervention within 2 years of presentation probably give the best outcome. This is one of the typical settings. This is a 9-year-old girl who presented with seizure. After 2 episodes of seizure, she underwent this MRI, and you have a lesion located in an eloquent area here. And therefore, to advise them surgery or not to advise them surgery became a question. Both parents, well educated, they themselves looked at the literature before they came seeking opinion again, and they wanted this lesion removed. So if you are operating on these kind of lesions, we have already talked about importance of DVI, importance of functional MRI, and we thought that there was a small corridor where we could operate, and the lesion was just in front of the Broca's area, and we went ahead for resection of this lesion. The main question in these kind of lesions is, should you be removing the hemosiderin ring? It seems that previous reports have probably told us that it is important to remove the gliotic surroundings or the hemosiderin ring. However, in such a eloquent area, it can become difficult. And this meta-analysis shows us that benefit of hemosiderin excision were probably not significant when you compared them with the seizure duration and the lesion diameter. And therefore, we decided to go ahead with surgery. This could be approached through a sulcus, a typical Mulberry lesion, and we tried to go around the lesion, not being very aggressive about the hemosiderin at the time. After the lesion came out, you saw that half the hemosiderin ring is gone and rest of it could be easily peeled off. So we ended up removing this lesion completely. This is about 5 years now, 6 years now, and the girl has no seizure. She is off medication, and she is actually training in a tennis academy. So if you have planned it properly, you can probably take out lesions from the eloquent area. We have seen some wonderful surgery videos before this, but even a subcortical lesion, sometimes this can be an important issue. These are the post-operative scans. while it is a more complex problem, when this girl actually I had operated at the age of 11 years or so for a right parietal cavernous malformation with a large hemorrhage, and she was quite well. And she had a small lesion which continued to bleed, and she started having seizures after 3 or 4 years. And this was situated in the temporal lobe. The seizure started with speech arrest. So we had to do a complete awake surgery and used electrophysiological monitoring as well, and managed to resect this lesion completely. I think in adults, it is very well accepted that brainstem location and history of previous hemorrhage or evidence of previous hemorrhage on imaging is the most common risk factor for repeated hemorrhages, and therefore I think this is a clear indication for surgery if a patient has a lesion in brainstem and patient has bled more than once. In children, there have not been many cases reported earlier. This is one of the first reports in 97 where 27 children were assessed, and they talked about reasonably good results in the children who were operated at that time. This is one of our patients. She is a girl going to high school and presented with a 6th and 7th nerve palsy with this lesion situated anteriorly. Again, further assessment showed that the lesion was coming to surface a little anteriorly near the trigeminal root entry zone, and we confirmed that with DTI and went ahead with a retromastoid approach. And what Dr. Lawton showed us near the trigeminal, just below the trigeminal, sort of trigeminal corridor, where you could see the lesion coming subpially, and then this lesion was gradually excised. Though there was history was only suggestive of one hemorrhage, but obviously you can see from the lesion and the hemosiderin surroundings, etc., that this lesion has probably bled more than once, and some kind of a granular tissue you can see surrounding it. So the timing of surgery, as Dr. Lawton was saying, is very important. You have to get them before they create this kind of a reaction. At the same time, operating early can also be a problem if there is a surrounding edema. So more and more, it was about 4 big lobules. The third one is coming out. And this is the last nodule which is coming out, after which you start seeing the pia on the outer side and the gliotic brain on the inner side. This patient in about 3 months recovered from 6th and 7th nerve palsy, and she is back to school. When you have a lesion which is presenting predominantly in the 4th ventricle, though it is not a very favored location, occasionally you may have to operate, and there the electrophysiology to get a good corridor, at least by trying to find the 6th and 7th nerve, becomes important. And this is how this lesion was almost completely excised. And this is the post-operative scan. The patient, this is the patient where we thought we have removed everything. And you can see that after making sure where we had to approach this, we managed to remove the clot first. We insonated to see where it was the closest, and we managed to remove this lesion, we thought, completely. But one of the problems is that this patient was operated within the first 2 weeks or so, and the opening virtually closed as soon as the clot came out, and we thought the cavernoma has completely come out. Post-operative imaging may not adequately help. Though we thought that we had removed the whole lesion, this patient came back with a bleed within 6 weeks, and we had to reoperate on this patient. And you will be able to see that this time we could get the glial surroundings well, to make sure that we have excised it completely. So occasionally very early surgery can make it difficult for you to visualize the lesion, because retraction inside the brainstem is not so easily possible. This boy took almost a year before his 6th nerve paresis recovered completely. I think there are papers about recurrence in the bleeding, and one of the most important reasons is probably inadequate visualization after the lesion came out. Dr. Lawton has written about 6.6% recurrence rate in brainstem cavernous malformation after surgery. And there is another paper which has come out recently, which talks about the possibility that there are some features which can probably give you an idea about recurrence. And grade 2 again, or type 2 malformations, and peri-operative perilesional hemosiderin ring was probably the only significant point which showed that there was a strong possibility of re-hemorrhage in these patients if you saw them on the post-operative scan. So this is another boy studying in high school who came actually with a 3rd hemorrhage. He was operated twice earlier, and I do not have previous scans to show, but there seemed to be a small nodule remaining after the end of 2nd operation at another center. And now he came with a full-blown CP angle syndrome, cranial nerves, as well as virtual lying in bed. And we went ahead and operated on this patient. The gliotic plane was probably much more helpful in this patient to give us a good corridor, as well as we have been able to get a good plane and managed to remove this lesion completely. This is the post-operative scan, and this surgery is about 8 years ago, and this boy is actually working as an executive currently at the age of 25 or so. Very rarely, this is in fact, there are 2 patients where we had to operate when patient not only bled and came in a bedridden condition, but continued to deteriorate. And we had to operate this patient within 24 hours as she became very drowsy. And we went ahead and removed this lesion after localizing the facial colliculus. We went ahead further lateral and tried to remove this lesion. Again, you can see the bulging margins of the brainstem make it very difficult to keep the cavity open. But here, the clot being more liquid helped us to remove it completely and to get a gliotic plane around it eventually. It took about 3 months to recover, but managed to recover fully. And this is a boy who presented with a thalamic hemorrhage in a very, very drowsy state, continued to get worse. After confirming that there was no AVM, we went ahead and evacuated this clot completely. And this boy took almost 3 months to get back to walking, and eventually managed to go back to school. Very rarely, like this patient was referred to me actually as a tumor. This 23 months, just under 2 years boy presented with right-sided hand weakness, inability to walk, and this was a large lesion. With multiple areas like this, we did think about cavernoma, and operated this patient through the right superior temporal anteriorly gyrus. And we could get the whole clot out after removing the whole honeycomb of this tumor. This child is about 2 years post-op now, has a small scar here, but has improved except for some mild finger weakness. He has improved completely and is able to manage to go to school. Occasionally, we have seen cystic and very large lesions. This 14-year-old girl actually was referred to me as a craniopharyngioma because of the calcification and the cyst which was going down to the supracellular lesion. And we were not sure, it looked fairly odd. And therefore, we went by a middle frontal gyrus approach. And you can start seeing that as soon as the cyst was drained, you could see the typical honeycomb appearance of the cavernous angioma. And at the bottom, it was attached to actually the right optic nerve, as you'll be able to see at the end of the procedure. And that's why probably she had some field effect. This is a postoperative picture. I mean, repeated recurrent hemorrhage seems to be the more common reason why cystic degeneration can occur in this, but probably the osmotic ingredient also pulls in more fluid. And we have now about 5 cases with a predominantly cystic lesion. I think cyst formation is equally common in both the genders, whatever cases are reported. There are very few cases reported on this. But one problem can remain is the angle of vision. Like some of the videos which were shown today, if your angle is not proper, the cyst might get drained, but in the wall, you may leave behind cavernous angioma. So you need to plan properly, just like you would do for any other large lesion. And we wrote about this recently in Child's Nervous System. About familial and multiple cavernomas, sometimes it can be a very difficult decision. For this kind of a patient with an occasional seizure, I think observation is warranted. However, this boy at the age of about 14 or so developed this hemorrhage, which was operated on at another center, and they sent for opinion for this cavernous angioma in the lower pons. We decided to wait because he had no other deficit. However, 1 year later, he came with another increase in the hemorrhage, a 6th nerve palsy, which had almost completely improved. And we said, if he has completely improved, we'll wait because we could not think about any corridor to go here. This was in 2003, as you can see here. However, within a month, he re-hemorrhaged and developed a 6th, 7th, and gross ataxia. So we went through the 4th ventricle and removed this lesion completely. This boy recovered fully. Today, I may probably reconsider that approach. We did not have DTI at that time available with us. So familial cavernous malformation, I think there is more and more being written about it. This is a paper, Dr. Lawton is one of the authors in this paper, where they have specifically talked about early surgical intervention should be deliberated. But if the patient has bled, maybe you should consider surgery early in these patients. If I have not understood it properly, maybe he can clarify on this. And there have been some gene changes which have been shown, like polymorphism here, and these 3 changes which have been shown have all pointed to their emerging prognostic value for the new perspective on risk stratification and personalize more strategies. This is one of our patients, the last case I would show, who presented with a large cerebellar hemorrhage. This boy was in school at this time. We removed this and he got back to school in 6 weeks. A fairly large malformation, I think, did not. But we have seen that the patient had also a small cavernoma on the opposite side, though it looked more like a punctate variety. And I had asked them to come back for a follow-up within 3 months. When the patient came for follow-up a little early, he was in a similar state with a large hemorrhage. So how long to wait for such patients also probably becomes an important consideration. How, I mean, this outcome in this patient was good after removing the second cavernous malformation, and he is now gone to engineering school. But I think some of these prognosticating factors are very difficult to determine. And as Dr. Book was saying, it is very important because they have more than 50 odd years in front of them when they suffer this. There are 2 or 3 papers written about cavernous malformation in pediatric age group. This is about 40 odd cases, and most of the findings which we have talked about have been written in this, though they had a fair amount of spinal lesions. In our series, we have not discussed any spinal lesions, but we have only 3 children with spinal cavernoma. I think this is one of the largest series from India, from All India Institute, where they have talked about 50 patients, out of which 6 were spine. And the findings are very much similar, that they have used conservative approach in most of them, unless they have bled more than once. I think Dr. Spitzler will probably allude to this in his series of 40 children. He has also used the same argument that given the greater life expectancy of children, surgical treatment seems warranted in those with surgically accessible lesions and have bled. I think there are now more information available to patients through some of these organizations like Angioma Alliance and Cavernoma Alliance in UK. And one of the papers which has come about, I think with their initiative, is the influence of physical activity on cavernous malformations. And more than 195 patients have been put these questions, and aerobic activity and non-contact sports do not seem to increase hemorrhagic risk. However, contact sports should be avoided is the message given by these people. This is another recommendation made by this alliance as to how these children should probably be active in cycling and various sports. And there have been now certain genes which have been associated with higher tendency to bleed, and PDCD10, I think protein probably suppresses endothelial fibers, and this has been found to be the mutation which is probably important for future. People have also used propranolol in familial cerebral cavernous malformation, but this is still in trial stage, and we do not have any definite idea if it will have a protective effect. So thank you for the opportunity, and I'm happy to answer any questions.
Well, thank you. That was a very nice overview. One of the questions on the chat room, Chandrasekhar, is if you see residual malformation on the postoperative imaging, do you always take them back for surgery and get it out, or do you observe? What's your approach to those?
If it is in an inaccessible area, I mean, sometimes it can happen if you have not gone through a proper approach. It may probably be a consideration to go back again. And I have actually gone back 3 times to take out cavernoma after recurrent bleed out of this 100 odd patients. And most of the, like one case I already showed, most of the times the problem has been when I have operated early and found it difficult to see all the margins of the residual cavity. So yes, I think if you decided that it should be operated in the first place, unless there has been a problem with neurophysiological monitoring, and if you cannot come up with another approach, then maybe those cases could be for radiosurgery, but I have not referred any patient to radiosurgery in my experience.
Next question. We know that in long-term follow-up studies of children who've had completely resected arteriovenous malformations, that they're at increased risk for late recurrence, often 8 to 10 years out from an angiogram negative resection. Do we know if children with CAV-MALs are at increased risk for late recurrence?
Actually, I have only one recurrence in children, which was a cerebellar malformation going through the middle cerebellar peduncle, and a small capsule was left behind there. And this patient rebled in about 10 to 11 months. So I have only one experience, and it happened within a year's time. So on long-term follow-up, there does not seem to be much evidence in literature so far. I am sure people with larger experience can give us some idea.
Yeah, and this next question is for any of the panelists who may have experience, but there are some case reports of using laser interstitial thermal therapy to treat deep-seated cavernous malformations. I'm not aware of any long-term follow-up of trying to ablate CAV-MALs with laser, but does anyone have any experience or thoughts on it? Michael, Robert, I'm sure you've probably seen patients who've been treated that way and then have come to you for other therapy.
You know, I think it's difficult to ascertain whether it's all gone, and it's a little bit. I think in our shop, Chris Smith did a couple of them, and I mean it makes sense. Obviously, either heat or cold, you can destroy tissue, and that includes abnormal tissue. The question is really the ability to get it all without hurting the surrounding structures. So it has not taken off to the best of my knowledge. I know that we dropped it, so I'd be very interested to hear around the world whether there are any that are doing. I'd like to make one comment, if I could, in regard to follow-up of patients. We've got to remember that cavernous malformations, and this really goes back to the very first presenter who wondered about this. There, especially in familial cases, the ability for new cavernous malformations that develop was very nicely demonstrated by Dr. Zabramsky in yearly scans, MRI scans, where you had a 6% incidence of a change or a new cavernous malformation occurring. And so when we do studies trying to determine the risk of bleeding, going back to the assumption that they have occurred really at the time of birth is completely wrong. And that gives us a false low bleeding rate, as we have false high bleeding rates when we look at series like mine or any referral center where you get cavernous malformations that have already bled and then go back from the last bleed and calculate a bleed rate. And that's how you get that high 60% that was developed in Japan. I personally think a reasonable bleed rate without good scientific foundation is in the neighborhood of 5 to 7% for brainstem cavernous malformations that have bled. And I want to compliment our last speaker. I think, Chandra, that was really a terrific, thoughtful presentation. And I agree with the philosophy that you have presented.
Well, thank you. And I see no other questions, Naren, so I think we're ready to move on.
Sorry, I was mute. Before we move to the next talk, if I may just ask a question to Dr. Boop, Professor Deo Pujari, and Dr. Svetzler. I have seen these occasional reports about use of beta blockers or interferon alpha for cavernomas. Interferon alpha is more for extra brain, systemic cavernomas. Have you come across any cases of such management and been successful? Dr. Svetzler?
No, I mean, if you're using interferon, you're talking about the cystic cavernous malformations.
And any propranolol beta blockers, have you come across any cases of that? No. Okay. Thank you.
Those are ongoing studies. I think I always have a problem with throwing something systemically at an organism to try to treat one particular lesion like a cavernous malformation. So if you try to attack the endothelial cells, well, endothelial cells don't just exist in cavernous malformation, they exist throughout the body. So one has to be very, very careful about considering the systemic negative side effects of any treatment that's directed at a very specific lesion. That's why really focal treatment for me is much more attractive.
Thanks. Thank you, Doctor. Thank you very much, Dr. Svetzler. That makes very much sense. Thank you. So for want of time, again, we will move to the next lecture. It will be from Dr. Josh Patel, but I'm going to invite Dr. Aaron Gadol-Cohen to chair and introduce and chair their lecture. Dr. Aaron Gadol-Cohen, I'm sure you all know of him, and he trained at the University of Southern California, then did his residency in Mayo Clinic and fellowship in Yale, and then skull-base fellowship in Arkansas. Dr. in Listserv has an initiative of having a video atlas, but what Dr. Gadol-Cohen has done is absolutely magnificent. Even when I was a resident, I found it absolutely useful. The neurosurgical atlas is as a bigger contribution in my eyes to neurosurgical training, and it will be a huge legacy for everyone that he's doing for everyone around the world. So it really is an honor to invite Dr. Cohen to introduce Mr. Patel and to chair the session. Thank you, Dr. Cohen Gadol. Thank you.
Thank you so much, Naren. I also appreciate all the incredible work you do with Listserv. Really, it's a huge legacy and immense contribution to neurosurgery. We all know that. I read every one of the emails in detail, by the way, and I very much enjoy it every day. So I wanted to thank you again for getting me involved. I know Dr. Patel is going to talk about a very important topic, but before I introduce him, I want to mention some personal perspective here that I think cavernoma surgery is the most straightforward surgery a vascular microsurgeon and a skull-base surgeon does. It is really straightforward and simple. There's except two issues that commonly challenge us. One is assessing risk, which patient deserves to have surgery, and number two, in those deep brainstem cavernous malformations, how we can safely avoid residual cavernoma because the corridor is relatively small and the operative blind spots can be wide. Besides those two, this surgery is extremely straightforward and a lot of fun, in my opinion. So technically, it's really straightforward. So I'm very thankful to have Dr. Josh Patel today to talk about the first challenging one, and that's assessing risk. Which patient deserves surgery and which one doesn't? And I think this is something that very much affects our outcomes in this surgery. And so Mr. Josh Patel is the head of the Department of Neurosurgery at John Radcliffe Hospital, Oxford. He undertook his residency at Belfast and was a visiting fellow at BNI and has been a consultant neurosurgeon in Cambridge and Sheffield before going to Oxford to take on his current post. And I sincerely appreciate his input and a thoughtful expertise about assessing risk in handling these lesions. Thank you, Josh, and please go ahead.
Thank you very much, Professor Cohen Gadol and Naren. I'm just going to share my slides and just let me know that you can see them. Can you see them?
They're just coming. Yes, we can see it now. Yeah.
All right. Okay.
And you just have to maximize it, otherwise it's coming through fine.
Okay. Sorry, can you see it now? It's maximized.
Yes, it is. Yes, thank you.
Okay. So thank you very much. Now, what I want to do in the next, hopefully 40 minutes, is I want you to stop thinking about cavernomas that you have been thinking about so far. And I'm going to present a completely different concept of thinking of cavernomas. So this is a talk about assessing risks. And actually, the real title of my talk is this: Delayed Enhancement of Cavernomas. This is a possible tool in order to evaluate the natural history, assessing operative interventions, and the effects of stereotactic radiosurgery. And it will try to address some of the questions that we've had in the previous talks. This is just a broad brush view of the bleeds that are quoted in the literature. And you'll find many different quotations. Essentially, a first bleed is 0.4 to 2%, second bleed are much higher, said to be about 8 to 10 times, as you can see. Asymptomatic and symptomatic bleeds are similar, low, and you multiply that number by 4, is 4 times with symptomatic bleeds. And that's from a meta-analysis. If we now look at deep and brainstem cavernomas, and I've reviewed this literature extensively for over 20 years, and I'm just giving you ranges for deep cavernomas, which is 0.7 to 5%. Multiply that by about maybe 4 or 5, and you get a risk of, 6 times, maybe 4.5 to 30% for rebleeds. And it's the same for brainstem cavernomas, 2.5 to 7%. And that's about 8 times, in fact, for rebleed rates. So that's in the literature. So as you go centripetally, the cavernoma risk of rebleeds gets higher. Now, there are various authors who looked at various risks. If you look at Bradley's series, which is a pooled analysis, he said that if you had a previous history of a hemorrhage and they were deep or in the brainstem, there was a higher risk of a rebleed. It wasn't the case, however, with age, sex, location, size, multiple cavernomas, or DVA. Fleming, on the other hand, also found history of hemorrhage was significant, but he also found that males were more dominant in multiple cavernomas. What he also found in his study was hemorrhage risk decreases with time with cavernomas. A study by Cavernous in 2018 showed that, again, previous hemorrhage risk, less than 45 years, 5-year-olds, Infertinatorial, or the presence of a DVA, increases the risk of cavernoma bleed. And then recently, there's been a paper by Zubier, which is a team from Scotland, and they showed that antithrombotics, in fact, reduces the risk of a hemorrhage. And there is a short paragraph about the mechanism of this, which to me, in my mind, is difficult to understand. Now, there is a single case report of a delayed enhancement of a giant brainstem cavernoma. And this was done in order to identify it, whether it was a tumor or not. It gave contrast. There was intense enhancement 1 hour later on an MRI scan. And it was a paper by two. What I really didn't realize at the time that Willem Koeker was the senior author, and he worked in Oxford himself. And then there are dynamic contrast enhanced studies that was done by Hart in 2013. And this was a quantitative study where they looked at the transfer rate of gadolinium and compared it to the white matter around it. And actually, they found that there were changes in cavernomas relative to the white matter, but they didn't know what it meant. So that was in 2013, nearly a decade ago. Now, epidemiologists, when they consider cavernomas, they look at the variability in the occurrence of any disease, in fact. And here they will be looking at the variability in the occurrence of hemorrhages, of cavernous malformations. And they use various models. They use binomial, Poisson, exponential distributions. Essentially, all these things, it's been shown in Oxford University that they identify the occurrence risks, essentially. And then what we do is we do clinical studies. And at the moment, there are lots of papers written because they are samples, essentially. And that's why we turn them into meta-analysis. And we get the sample statistics. And we use those statistics and that data, and we apply it to population statistics. And then we take that population statistics and we go to our patients and we say, this is the risk of your cavernoma in the brainstem of it bleeding. And then we start discussing the pros and cons of treatments. Well, the question I'm going to ask and I try to address is it possible to identify the risk of a bleed of an individual cavernoma? So you might even have 2 cavernomas in an individual patient. Is it possible to identify the hemorrhage risk of an individual cavernoma? So historically, if we look at studies that evaluate cavernomas, They're either anatomical or physiological. And in fact, all the literature talks about anatomical studies. And essentially, we do CT scans, or they were done historically, and MRI scans with gradient echo and SWI. The physiological studies are contrast CT scans and angiograms. They were done in the past in the 60s. And of course, now contrast MRI, MRDSA. Now, delayed enhancement was first proposed in 1960. I found a textbook where Yazagel proposed that. And I found this case report, which I mentioned, the giant cavernoma. Delayed enhancement is also quoted in the literature, even up to 2019, for use in multiple sclerosis, where they use dose variation. But there are no real studies on the immediate or delayed enhancement of cavernomas in the literature. Now, the natural history of cavernomas is kind of somewhat characterized. I think we have some statistics that we all discuss with. But it's not possible to predict the behavior of an individual lesion. Now, some studies indicate that gamma radiation or stereotactic radiosurgery of any form reduces the rebleed rate. But others argue that this is the natural history and cavernomas remain visible on MRI scans. So that is the controversy with surgeons say. And they say the risk of radiation to eloquent areas are unjustified when treatment is unproven. On the other hand, surgery, whilst it's definitive, is not without risk. And others argue that stereotactic radiosurgery is still a safer option. Now, delayed enhancement of cavernomas could assist in three things. The natural history, it could assist with us being able to assess our operative interventions and whether stereotactic radiosurgery does indeed work. Now, if you take a cavernoma and you don't give it contrast, you get a pre-contrast scan. And then on the immediate views, when you give gadolinium, it shows variable enhancement. But because cavernomas are considered to be extremely low flow lesions, I hypothesized, and this was an idea I got when I was returning from the barrow in the aeroplane, that delayed images after contrast would reveal their true nature. So I did this study when I was in Sheffield over a decade, and I continued the work in Oxford. And essentially, it's a small series, but I want to show you the principles. And the last 5 slides are probably the most important at the end of the talk. So there were 13 patients, and that's the age and genders, and there were 18 cavernomas. Now, some of the cavernomas that present here, and although they add up to more than 18, are actually the same patient, same cavernomas, and their treatment follow-ups, essentially. And they presented with, there were incidental, 3 of them, 3 with events, 6 with hemorrhages, seizures, and an increase in size. Now, I'm very clear about the definitions of event or episode that I use and hemorrhage. For me, a hemorrhage means that there is no evidence of hemorrhage on a scan if you can't see it from a previous scan. If you don't have a previous scan, at least you need to see overt hemorrhage, which is intralesional, extralesional, or intra and extralesional. An event, it can be the same thing, let's say a motor cortex lesion that causes symptoms of weakness, but when you scan the patient, there is no change. So that's called an event, because that might be due to a microhemorrhage, for instance. Okay, so now let's just come to patterns of enhancement. Now, if you take if you take a cavernoma and you do a pre-gadolinium scan, it doesn't enhance. So if you look at the notation below, you can see 0, 0, 0, and so on. So all of them start off with 0, no enhancement. If you then give gadolinium, then you may get enhancement or you might not get enhancement. So if you get enhancement, I score there as 1, so it's a 0, 1. And if you don't get enhancement, it's a 0, 0. And then if you do a delayed scan at about 20 to 40 minutes, and I only chose this time because I was thinking about practicalities when patients get scanned, then the cavernomas will either enhance, not enhance, enhance the same, or they will enhance further. And in essence, you get 3 types of patterns, 0, 0, 0. So if you look at the notation at the bottom, it means that the cavernoma did not enhance at all. And if you look at the last one, it didn't enhance on the scan without contrast, which it wouldn't. Then it enhanced on the immediate scan, and 20 to 40 minutes later, it enhanced even more. Now, there are 2 other things to consider. A cavernoma is a 3-dimensional object. So rather than area, one has to consider volume. And one has to consider brightness, which is the luminosity. So I remark these at L minus, which means that it has become less luminous. L0 is the same luminosity, and L plus it's become more intense. And the area of volume indicates that the extent of the cavernoma is either beyond, less, or the same. Okay, so these were the results now, and they're quite simplified. Now you can see in 7 cases, I got 0, 0, 0. In 14 cases, I got 0, 1, 2, and 0, 1, 1 in 4 cases. But in 2 of the series, I got no enhancement at all, as you can see, 0, 0, 1, 0, 1, 0. So let's just look at examples. This is a patient who is 54 years old, and she essentially presented with a brainstem hemorrhage, and I operated on her. So this is a left midbrain hemorrhage, and you can see the pictures on the left side, and on the right side, you can see my scar. But as you went, she also had further cavernoma. She had one in the midbrain, which is exophytic, associated with the DVA, and she also had one in the right midcerebellar peduncle. Now, she then presented 5 years to the day with another hemorrhage. I was concerned because it was in the brainstem, thinking I'd left another cavernoma there. So we're talking about 2008. But this time the cavernoma was on the other side in the midbrain. And when you give contrast, if you look at the areas in the periphery where the vessels are marked, you can see that they enhance, but the cavernoma doesn't. So essentially I had 7 cavernomas that had bled, which didn't enhance. And then I didn't have any cavernoma series with 001 and patterns or 010 patterns. Now, what does that mean? 010 means that cavernoma didn't enhance on a non-contrast scan, then it enhanced, and then it washed out soon after. Now, but I had none of those. But that's an important category that I'll talk about at the end. Now, the 011 categories, I just want to show you examples of this. This was a 14-year-old child. He was a sibling in a family history of another patient who I have in my series. And he had a right frontal hemorrhage, which was treated conservatively. He didn't want an operation. Now, if you look at this picture, on the right-hand side at the top, you can see the timing of the cavernomas as well, 1312. And then you see the next picture is 1319. But look at the cavernoma, it changes. And then it doesn't really change much, not totally convincing, but this is the pattern essentially. So if I go back, this is the 011 pattern. It doesn't change much on that pattern, okay? And this is essentially at 26 minutes past. So it starts off at 12 minutes and 26 minutes later, it's still really not really changed much. So that's about 14 minutes later. So let's just move on. He also had another cavernoma in his pons and medulla. And that also had bled, and HH stands for 2 bleeds, and he was treated conservatively. And that's his cavernoma there. Again, identical scan to the previous ones I've shown you. And you can see it in the posterior fossa, something subtle at 1312. 1319, you can see a DV associated with it. And then this is a slice slightly higher, but washes away. I've got the original slides, which shows that it washes away. So again, similar pattern, not totally convincing, you might say. Okay, so we'll live with that. And then let's look at the next series, which is the 012 pattern. Now, in this pattern, the cavernoma essentially enhances first and then enhances further after waiting for 20 to 40 minutes. And I'm going to demonstrate luminosity over here as well. So here, this was a patient who was 24 years old. He presented with a hemorrhage before I met him 2 years before. He didn't want treatment. And then he started to develop a hemiparesis, and he went to the stereotactic surgeons, who then referred him to me because his cavernoma had increased in size. It was in the thalamus in the brainstem. And when I met him, that was his cavernoma. So I offered him surgery. And so that was in 2005, December. This is in 2006, post-surgery. I had to stop. I couldn't get the whole cavernoma out because my anesthetist was unhappy with the changes in the blood pressure. So I'd done a Trans-Colossal approach, contralateral, and my aim was to try and get the other half in future. However, he refused surgery. So I was left with this. And that's in 2007. So he then presented with a subclinical hemorrhage, and he developed some symptoms again. So I had a long discussion with him, and he opted for stereotactic radiosurgery. So here, if you look at the cavernoma and look at the timing, which you can see at the top, which is 1028, and then you give him contrast, and you can see it enhancing, and then you wait further, and you can see it enhancing further. So I'm just going to go through the slides again. So that's the non-contrast scan, and there's a subclinical bleed you can just see at the right and bottom side. And then here you can see that he's enhanced a little bit, and then enhances further. So you can see that on the delayed scans, there is evidence of these cavernomas enhancing further after 28 minutes. Now, he then this is the first patient ever, in fact, who had gamma irradiation in Sheffield for cavernoma. Now, she is 41 years old, or presented to me at the time. And when she was 16 years old, she was writing her exam in school, and she started to develop a weakness. And at the time, she presented with a hemorrhage, and she was treated for her cavernoma 2 years later. So you can see in the basal ganglia on the right-hand side, there's a subtle feature there. If you look at the clock at the top, and then 29 minutes later, you can start to see that. You wait another 10 minutes, and you can see that. So you can see these cavernomas have patterns where they enhance further the longer you wait. So here, there are two cavernomas I've demonstrated with 0-1-2 patterns. Now I'm going to show you a cavernoma where I was uncomfortable, and I figured that 0-1-2 patterns have a higher tendency to rebleed. And so this 34-year-old gentleman presented to me. His job was, he was a salesman, so he had to do two things. One was to drive, so he could not lose his license, and if he had a seizure, which he had, and he was seizure-free for a year. And secondly, he had to speak, and he had presented with dysphagia at the time. So he presented with this scan in 2007. So that was his hemorrhage at the time, and I had a long discussion with him. He decided that he would opt for conservative treatment. And I met him, I obviously repeated the images, and I assessed him again. In June 2010, when I saw him, I studied his cavernoma again with delayed enhancement. So this is non-contrast scan. In contrast, you can just see something, and you can just about see something further. Now, so this is after at least 40 minutes, and there's an area which enhances further. So here, if I'm going to show you three particular slides, this is very subtle, but we measured the intensity on the MRI scanners quantitatively. And around the periphery, there's a rim. And in this rim, you can see on the subsequent scans, the 3 scans, 44 minutes later, that actually there is an area that is enhanced. In other words, the cavernoma luminesces, and then if you wait long enough, it then goes beyond this boundary to start to enhance. Okay, so now I therefore discussed treatment with him, and because he was concerned, he'd now got a cyst that had potentially bled. And when we got to treat him, these were his scans, in fact. So that's the frame. You can see the dots on either side when he did his gamma knife treatment. He didn't want surgery because of his speech and seizures. He was worried about that. And you can see at the time when we gave him his gamma knife that he'd actually bled at the time. Now, if I show you this particular scan, that's now 3 years later. This is a non-contrast scan, and then this is a further contrast scan. So it's remained stable during all this time, actually, and beyond that. And he's continuing in his job. But we heard some excellent talks into how to approach these particular areas to try and remove these cavernomas, but not without risk. Now, I'm just going to present to you a cavernoma in the spinal cord. So here is a patient who is 51 years old, and she presented to me with a hemorrhage and then an event. And so she had that scan. It's a T2, and you can see the expansion of the cord around the C3-4 junction. And with contrast, non-contrast, sorry, you can see that the expansion doesn't take up any contrast. Subsequently, when she has the immediate scan, you can see 17 minutes later, not much of a difference. Wait another 14 minutes, and you can see the cavernoma enhancing. I excised this lady's cavernoma. So you can see, so I'll just go back, non-contrast, immediate, and delayed. So when you wait, you will indeed see more of the cavernoma. Right, now I'm going to show you two particular aspects. One is the pre-operative and post-operative scans on an example of a cavernoma. And then I'm going to go and show you pre-radiosurgery and post-radiosurgery of one case to try and demonstrate whether it actually makes a difference or not and whether it could be a useful tool. So this particular patient, BBW, he had a hemorrhage and his cavernoma essentially didn't enhance. Subsequently, it enhanced to 0.12 post-surgery. And I'll tell you a story. So I met him in 2006. He'd actually bled 6 months before, but he had a rebleed, and that was his cavernoma. And one of the things that we've discussed with cavernomas is which approach to use. Now, when you see a cavernoma like this, you don't know where the cavernoma is. You know where the hematoma might be. So whatever approach you use, I studied the scans very carefully, including the CT scans, to try and work out where the hypodense blood is and where the cavernoma might be, to try and, so that when I do remove the hematoma, I'm also targeting with my approach the cavernoma itself. So after surgery in April 2006, this was the result. And when he had a contrast scan, that was the result. So essentially, it doesn't enhance. And in fact, the report said it was a formidable resection. Fine. He went off to China, where he became a teacher. And 3 years later, I got a phone call from him. He said that he wanted to return. He'd taken amphetamine. He used to train and run up a hill with a 20-kilogram backpack. And he got a headache. It was reviewed in China, and he came with his scans, and he had a rehemorrhage. So this is a scan now at 10:11 on the right-hand corner, you can see. And if you concentrate on the area over here, so then subsequently at 10:29, you can just about see a fluid level. And then a third scan, you can see at 10:40, it definitely enhances on the delayed enhancement scan, which you didn't see on the original scans. So he then I offered him surgery and I offered him gamma knife. He opted for gamma knife. And he had his gamma knife in October 2009. And now I'm just going to show you what happened to his pattern. His pattern was 0.12 post-surgery. So pre-surgery was 0.12, which I've just shown you. And then subsequently, after his gamma knife, you can see this is the non-contrast scan. This is the contrast scan. And this is the scan afterwards. So it washes out. Now the timing for the initial series was 29 minutes, and this is 33 minutes. Within 19 minutes is in fact washed out. So the stereotactic radiosurgery has attenuated the cavernoma in such a way that it has washed out the contrast sooner than one would expect in the pre-stereotactic series. Now, so to just come to a conclusion now and a thought. So when patients have cavernomas with a 0-0-0 series, in other words, they don't enhance at all, even when you wait 40 minutes. It's possible that the hemorrhagic areas did not appear to enhance. And it's also possible that the contrast washed out so rapidly that we never really saw it. And it's possible that therefore that they might have maximum resistance and no flow, or minimal resistance and very high flow. And these cavernomas might be thrombosed and stable. Now, with the 0-1-1 pattern where the cavernoma enhanced, but 20 to 40 minutes later stayed the same, what I found was that the luminosity, in other words, the brightness increased, but it rarely stayed the same or decreased. So they were bright, essentially. The luminosity increase might reflect low resistance. In other words, they light up very quickly, and they have high flow. And these cavernomas are probably inactive and probably stable. Therefore, for the 011 pattern, they might have low resistance and high flow, and they remain inactive and stable. Now, with the 012 pattern, where the cavernomas enhance significantly, if you look at the area that's beyond which the cavernoma is, they enhance even further. So either the area increased or remained the same, and that's what I found in the studies. It rarely decreased. And in these cases, what I found was it's probably the high resistance vessels are now where the blood starts to flow through, and therefore you have low flow. And these cavernomas are probably active and unstable. And I suspect what probably happens is the 012 pattern, which is active and unstable, tries to bleed to become inactive and stable, and tries to bleed further, maybe to thrombose and obliterate itself. So I'm just going to show you this model now and help you to think it through. So if you imagine the inner circle here is the cavernoma, the outer circle is also the cavernoma, but with its peripheral margin. And it's made up of a series of parallel vessels with resistance. There are 10 ohm resistance in the central ones and high resistance in the peripheral one. Now you've got the venule on the right-hand side, you've got the arteriole on the left-hand side, you've got normal capillaries outside this cavernoma. Now, if you had a predisposition, like a genetic predisposition to a cavernoma, and or let's say you were irradiated for a medulloblastoma or whatever, then it's possible that with this predisposition, you developed venous stenosis at some point. Because of venous stenosis and abnormal sinusoidal vessels or genetics, the abnormal capillaries might start to dilate. And because the desmosomes are abnormal, they may leak blood through. And that might be the inception of the formation of a cavernoma. Now, the vein which normally drained that part of the brain, because it's stenosed, cannot drain there further, the tributaries start to expand. And they might start to expand in the form of a caput medusae, which is why you get your developmental venous anomaly. So that might be the reason for that. Now, because we are, if you look at the right-hand bottom autoregulation curve, because we are flow driven, which means that our cerebral blood flow is kept constant. What controls us is the cerebral blood, the cerebral perfusion pressure. So if you look at the equation on the left-hand side, V equals IR, voltage equals current times resistance. If the cerebral blood flow, which is the middle equation, has to be kept constant, if the resistance goes up on the right-hand side, the cerebral perfusion pressure must also go up. So therefore, across the artery and the vein, across the capillary, the cerebral perfusion pressure has to go up if the resistance is high. Now, if you remove the 10 ohm resistance, the pressure doesn't drop much. If it doesn't drop much, it's likely that it will try to bleed again to bring the pressure down in order to maintain the cerebral blood flow. What you find is if you remove the 100 ohm resistor, the peripheral area where you get higher amount of resistance vessels, then that brings the cerebral pressure lower to maintain the same amount of blood flow. What probably happens is that you get a bleed, you still got high cerebral perfusion pressure, the blood flow is still maintained, but it's still, the pressure is still high, so it bleeds again, and you probably get cluster hemorrhages as a result. So that might be an explanation for the cluster hemorrhages. So here, what I've proposed is that cavernomas demonstrate a variable pattern of enhancement on delayed studies. Now, it could assist our understanding of the natural history because we could look at the patterns in those, and maybe those form a pattern where they are 0, 0, 0, or they wash out quickly. We could look at our operative interventions where we think we've excised them completely, but maybe on the delayed cavernomas, we might see that actually they're enhancing further. And we might be able to look at the effects of stereotactic radiosurgery and use this as a tool to see whether it's possible to try and identify which cavernomas are likely to rebleed. I want to thank many people, the people I worked with in Sheffield, the radiosurgeons, my new radiology colleague who worked with me, my anesthetist. And this is my time in Barrow. And if I've seen further, which is what Isaac Newton said, it is by standing on the shoulders of giants. And I look forward to Professor Spetzler's talk. Thank you very much.
Great lecture, Josh. Really enjoyed it. Some thought-provoking ideas for all of us to think about for sure in management of these lesions. I don't have any special questions. I think there was one question about timing of the delayed contrast sequence in MRI. So if you want to further elaborate, so what is the timing of the delayed contrast sequence in the MRI you're obtaining? If you could discuss that further, thank you.
Okay, so because these were clinical scans, thank you. Because these were clinical scans, I used a random time of 20 to 40 minutes because there's always the usual, can the radiographer get a cannula in, and if the patients are elderly, will they be able to lie on the couch long enough? Or if there's movement artifact, they might want to get another series. So I used an arbitrary time of 20 to 40 minutes. Sometimes it took longer, up to an hour. The whole point was that you want to get a delayed scan. So you might want to get your other series, such as gradient echo, SWI, etc. And you might want to do that final scan right at the end. So, but you're not giving any further contrast. That's all you're doing. You're just looking at that final scan. So, but you need to understand that what you're looking at is time to peak. And maybe I missed the time to peak because that's not something that I was kind of looking at. I was just trying to identify whether these things enhanced later on. And if we could find out when there is a time to peak, we might be able to decide that if the time to peak is early because they flow very quickly, maybe these are the ones that don't bleed. But maybe if the time to peak is very late and the enhancement is further outside the cavernoma, it's possible that these cavernomas are more likely to bleed. So that was an arbitrary time that I chose.
Thank you. Any other questions?
Can I please invite Dr. Spetzler to?
Yeah, Yash, I enjoyed the picture of the two of us. It's a little hard to recognize you now in comparison. There's actually, I love people who think out of the box, but I think for you to prove anything with your theories, you're going to have a large cohort in order to test this hypothesis. It is very true that there is the flow in the cavernous malformations is very slow. I did a study which we never published where we injected ICG green and we measured the time of between when it appeared in the arterial circulation, which happened basically immediately as the bolus reached the brain, and the delay for when the cavernous malformation would enhance. And it would be minutes and sometimes up to 3, 4, or 5 minutes before you saw enhancement. The fact that radiation is much more likely to affect the arterioles and the arteries as opposed to the veins makes it difficult for me to accept that you think that radiation shuts off the venous side of your equation. And then finally, it would be true that as you shut off the outflow, that the pressure in the capillary bed would increase if the pump was right at the entry point. The pump is all the way back in the heart. There is a huge vascular bed, so that if you shut off an artery or a vein, that pressure in the capillary bed just moves right somewhere else. I mean, you would have to force that blood into that bed in order to increase the perfusion pressure, which will not happen. So I like your thinking out of the box. I really would love to see further studies, because making the assumption that enhancement and the risk of bleeding are associated, you have to prove, right? I mean, you can't just say that. We know we know Buzz Hoff, for example, who spent his entire life with a NIH grant funding, demonstrated the incredible damage that hemosiderin does to the brain. So when you have hemosiderin in the brain, you may very well be in a phase where you have a reaction which would lead to leakage and therefore enhancement. So I'm intrigued by your hypothesis, and I look forward to the next time around when you have more evidence that it is correct.
Thank you, Professor.
That's great. Thank you very much, Dr. Gadol Cohen. Thank you very much, Mr. Josh Patel. I mean, it's important to take the field, the Cavernoma to further understand. So it would be great to see how we'll hopefully have another symposium in 2 years' time. You can update Mr. Josh. Thank you very much. So now we come to the next talk or lecture, and this is from Dr. Robert Spetzler. If anyone in neurosurgery don't need any introduction at all, it will be Dr. Spetzler. I have not come across a resident or even a medical student with an interest in neurosurgery. You mentioned the name Dr. Spetzler. They are absolutely inspired and thrilled just to hear his name. So I'm going to ask Professor Miguel Arez to introduce Dr. Spetzler. And Dr. Miguel Arez is the professor and chairman at the Department of Neurosurgery in Malaga. He has been very active in the WFNS, had been previously the chair of all the committees, past president of the Spanish Neurosurgical Committee, and now the president-elect of the World Academy of Neurosurgery. Professor Arez, thank you, sir. Miguel?
Okay, sorry, I was on mute. Naren, thank you very much. Can you hear me?
Yes.
Yes,
Yeah.
thank you. Naren, thank you for giving me the opportunity to participate in this wonderful symposium with real giants of neurosurgery. And thank you for giving me the honor and privilege to say some few words before Professor Spetzler start his talk. How could I summarize Professor Spetzler? I don't want to take much of your time because we have to invest our time in listening to his presentation, but we can define him as the finest expression of brain and spinal cord microsurgery. Professor Spetzler is admired and universally acclaimed for 100% of the neurosurgeons. And I have to mention that I do consider myself the fan and follower #1. So from the personal point of view, Professor Spetzler is a very important part in a physician, in a surgeon. Professor Spetzler is a very warm person, is a very generous person, always teaching and transmitting his philosophy. And for the youngest colleagues in the audience, I invite and suggest to listening to many of his talk regarding his philosophy about neurosurgery and the way he created the BNI, that is probably the most famous neurosurgical institution all around the world nowadays, successfully run by Professor Lawton. I think that the name of Professor Spetzler and BNI cannot be dissociated. And well, apart from that, Professor Spetzler is one of the most prominent members of the World Academy of Neurological Surgery. He has received hundreds of awards. He has all the possible titles. He is honorary president of WFNS. He got everything. And of course, he deserves everything. I don't want to take much of your time. And I'm completely sure we are going to enjoy Professor Spessler presentation as always. Professor Spessler, whenever you like.
Can you hear me?
Yes.
Yes.
Sorry,
Very
I
well.
said some nice things about you, my friend Miguel. That was a very kind introduction, way over the top. I sort of wished my parents would have been around to listen to that introduction, because my father would have smiled and my mother would have believed you. I must say, Naran, this was an incredibly excellent symposium, and I'm sort of like the cleanup person, but I thought each and every presentation really had substance to it and well worth discussing. Can you see my screen?
We can see it.
It says I am screen sharing.
Yes. I think it might be that you have got two screens. We are seeing it in a split version with in a presenters mode.
Okay. Let me switch that. Okay, now.
Yes.
Yes.
Now, yeah, absolutely.
Okay. So I want to re-emphasize that I thought Dr. Lawton's presentation was really one that you have to spend a lot of time analyzing, because so much thought has gone into what I think cavernous malformations have really taught us, and that is avenues to the deep portions of the brain. Aaron mentioned it's straightforward surgery. It is straightforward in the sense that we have a target and we have a goal to get it out, but the way to get there safely is really the secret. And no other lesion that I know of has done more to educate us in this regard than cavernous malformations. So I've been fortunate enough to have had a lot of experience with these, and I'm not going to repeat everything that has already been discussed in such an eloquent manner, but I want to point out a couple of things. So here is an obvious cavernous malformation with a hemorrhage, quite symptomatic, and this patient had no treatment. And the point is that if you had radiated this particular patient at this point and then looked at this lesion 2 years later, you would say that is tremendous success. We have to be very careful in what we define as success. And I think the answer to what is the appropriate treatment depends very much on the individual presentation of the patient. We did not spend a lot of time on the symposium on the patients that we elect not to operate on. And for example, here is a patient that is basically asymptomatic with a cavernous malformation directly in the pons below the floor of the fourth ventricle. If we take this lesion out, we are going to have an unhappy patient and family. And it was a study that we did prospectively in evaluating patients that were sent to us for surgery. And we had 87 patients that came to us with brainstem cavernous malformation between 97 to 99. And what we did is we recommended conservative management in almost half of the patients, which emphasizes the selection process for those that we really operate on. And that is very, very important, because when you look at series of apples and oranges, and somebody operated all of these, they would have much worse outcomes. And if you only operate on very, very few of them, you would have a false impression of how safe the surgery is. Indications for surgery. I think it's been mentioned. Obviously, it has to be accessible. Repeated hemorrhages is a good indication. Progressive deficit is a good indication. Significant mass effect. And finding a way to get there that is safe. Safe entry zone is really the key. This has already been mentioned. I think they're always associated with abnormal veins. Whether it's an anomaly or not really depends. Prevalent studies, we've discussed this endlessly. And I think when you looked at rehemorrhage rate, this is a study that came out of Japan. 60% is obviously very, very much dependent on the fact that it's a referral center and patients have been entered because they've had more than one hemorrhage. So to get a 60% natural history rehemorrhage rate would be impossible. These patients just wouldn't be alive. In our own series that was reported, we had a rehemorrhage rate of 21%, and that suffers from the same problem. I personally use, when I talk to patients who's had a brainstem hemorrhage rate, I use the number 7%. I don't have a lot of basis for using that number. But these are complex lesions, and we must not forget that. I think there's no doubt in my mind that every experienced neurosurgeon or neuroradiologist with this venous malformation would diagnose this as a cavernous malformation. This is only a 7-year-old. And as Dr. Boop mentioned, the problem with AVMs in children, the recurrence rate of AVMs is so different. And that is something that is in a different talk, but of importance. So this patient was radiated somewhere else before they were sent to me. And I think we can all agree that it was a cavernous malformation. It's treated with Gamma knife. Now look at this 16 months later. Totally, totally different lesion. And this is what it looked like. Obviously now it's a thalamic arteriovenous malformation. And in my opinion, having already been radiated, it is one that needs to be followed and with probably not a particularly good outcome. What is the physiology of this? I think in my own mind, this is something that occurs from veins, and it's sort of a venous budding thing that occurs. So this is a classic cavernous malformation. You can see the large venous anomaly that's associated with it. You can see the enhancement. Here's the vein. Here's the vein at surgery. Here's the cavernous malformation, clearly part of this lesion. And a vein that goes into the cavernous malformation is not the same as the same vein a little farther out where it drains the normal brain. Here you can obviously take it, and that's what it was. I'm not really going to show you this video, but it's basically taking it out. And it goes very readily and looking into the lateral ventricle. And recovered well. So we are going to talk about approaches because I do believe that exposure is everything. I know I've said it 1,000 times, you're tired of me saying it, but we have to preserve the venous anomaly that drains the normal brain. These lesions cannot be done safely in many, many cases without image guidance. Monitoring, I share Dr. Lawton's question about its usefulness, but it is mandatory to do. I think it gives us pause. When there's a change, we can reassess the operative field. Sharp dissection, EEG burst suppression, know your anatomy, and I like to really operate without using retractors. Anatomy, 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 and I know this is music to Aaron's ears because anatomy is really what we need to study to find roots to these deep portions. Michael already showed the avenues for lesions that are relatively close together, how varied they are depending on their specific location. In 2015, my fellow and I published a series of approaches to the thalamus. Each one of these regions requires a different approach. And that is really based on anatomy, and it's based on experience. And here it summarizes just how you get to these regions depending on where the cavernous malformation is located in the thalamus. So a simple thing is you put a point, and we published this in 1996, a point in the center of the lesion, and then a point where it's safest to come out, either to the brain or to the skull. And then those 2 points determine your avenue. They determine your craniotomy. They determine your exposure. As already been mentioned, image guidance, microscopy, essential. Instead of doing this, which is sort of the routine, how we all learn, is placing a retractor, what we really should do is put it in when we need it. And if we don't need it, let's not put it in. I like for the patient to be comfortable. I like for me to be comfortable. And so that usually is something where you are looking at the lesion at 45 to 60 degrees. I like the sitting position because it makes me more comfortable and you have more support. And as we make smaller and smaller openings, we have more and more trouble with light because the light comes in at a different axis than the optical axis. And depending on your focal length, it can vary between 3 to 6 degrees. So you may very well be operating in shadows, and therefore adding on lighted instruments makes a lot of sense when you're operating on a deep cavernous malformation. Here's just an example of where we have come with resection. Here's a small cavernous malformation that has bled repeatedly in the medial occipital lobe. And what we're going to do is we're going to come contralateral. We're going to put the patient in the horizontal position, which I'll add on a little bit more. Now we've used the robotic function of the microscope to line up the entry point and our target point. And then all we have to do is follow this down. All we did was, there's no retractor in here. There's the lighted sucker. We've gone across the midline. We have the patient horizontal because our eyes are horizontal, our hands are horizontal, and that really makes it much easier for the surgeon to do the very best that they're capable of. So that's the contralateral side, just sweeping off the little vessels and taking it out. Little opening in the falx, no retractor, just gravity, horizontal position. When we see a lesion like this, we really need to spend a little bit of time in deciding how we're going to approach it. Sorry. So we see this lesion, and you have the ability to go retrosigmoid. You could come OZ. You could come supracerebellar infertinatorial, midline, or lateral, not irrational. You could use Kawase. But when you study this is cerebellum, this is temporal lobe, there's the tentorium. So in my mind, the safest approach through the medial lemniscus, which is very tolerant to incision, is to come that way. So we're going to come a lateral supracerebellar infratentorial approach that gets us right there. There's the sinus opening. We just tend to do a small opening. I think you can usually get down to the ambient cistern and then just give it a little bit of time for the CSF to drain. Or you can do, as Dr. Lawden did, open up the foramen magnum and get some out there. And and we take it out. I mean, it's really very straightforward to take this out at this point. No retractors, despite the fact that we're not in the sitting position, and getting it out. Here's a medical student. She's in her 3rd year of medical school. She's had an apoplectic event. Obviously, the worry here is memory. We're right by the fornices. So the question is, how do we approach it? Inter-hemispheric, or are we going to go through the lamina terminalis? Once you've decided, and we said inter-hemispheric trans-colossal is the best, then what position? I've already mentioned it. The vast majority of neurosurgeon would do straight up. I think by far the best position is horizontal, always going across the midline so that you can pull the dura and the sagittal sinus over just a couple of millimeters, which are important. So here she is, comfortable position for her, comfortable for me. We use image guidance. We come right down through the ventricle to the cavernous malformation. And this one, again, is very straightforward. What is important here is the searching around the edge of the lesion to see whether we leave anything behind, and taking out anything that looks like it could be collapsed tissue that could harbor residual. And here she is, perfectly normal exam. There was the incision, there was the opening, there's the empty cavity. How about here? Talking about the decision-making process. Transcortical, right frontal, perfectly reasonable, well tolerated. Inter-hemispheric trans-colossal, tough to make it all the way over to this without putting a lot of retraction on the inferior portion of that brain. Or contralateral, inter-hemispheric, through the cingulate gyrus, shoots us right there. And that's the one we chose. And so again, patient is going to be horizontal. We're going to have to go through the falx in order to get this angle for us. With image guidance, that's not a problem. We're looking down on the falx. Making an opening into the falx based on the image guidance. So we do it in the right location, and we're going right down to the lesion. I mean, right smack to it. Tiny little opening through the cingulate gyrus and gets us right to the ventricle and to the beautiful cavernous malformation. And then, like with every other example that's been shown, we take the little veins that are part of the cavernous malformation, just like this one here. You want to be sure you don't lose it in the ventricle. And then we take the lesion out. Came out very nice. I'm going to just show a couple of, I know we had a talk on spinal cord, but I want to give you my own philosophy on the spinal cord lesions. What is really important is to recognize our roots into the spinal cord. We have the midline myelotomy that we all know and that we love. We have the substantia chelatinosa or dorsal nerve root entry zone, which is a very safe corridor. And then we have between the nerve roots at the level of the dentate ligament. I do not think an anterior approach makes any sense because you have these circumflex vessels, which you have to interrupt to have any sort of longitudinal opening. So those are the three approaches for the spinal cord. This is a giant lesion. This was a long time ago. Patient still had a tiny little bit of function, 10 years old. Here's the bed. I don't know where there's any spinal cord, but still had a tiny bit of function afterwards, but should have been operated on much earlier. Here you can see the nice association of abnormal veins in the spinal cord with cavernous malformation. This is a familial cavernous malformation. And this is the son and the dad, and they both had lesions at exactly this location in the spinal cord. Well, unfortunately, he had a major bleed. He came to the hospital and still had, was transferred from another institution, still had some sensation in his legs. We operated on him, but he was severely impaired. Incredible attitude. 8 weeks after this happened to his son, Dad said, I want mine out. So here it is, and here it's out. More interesting are those that are not so easily accessible. So here's one up to the front, presenting with pain. So this is perfect. Here's the dorsal nerve root. So we're going right through the dorsal nerve root entry zone, which also helps his pain control. And we get right to the cavernous malformation. Very nice exposure, allows us the removal of this lesion without any trouble. I used to say you're never bipolar in the brainstem or the spinal cord, and naturally it's nonsense. It works very well. More difficult is this one here, which is up front. And this was a Hong Kong businessman, AAA personality, looked all over the world. So this is what we did: dorsal nerve root, dentate ligament. So we went right between the nerve roots at the level of the cavernous, of the dentate ligament, getting right to the cavernous malformation, sharply dissecting around it, allowing us to take it out. And you can see the different ages of the hemorrhages that were related to the different symptomatic presentations of his bleeds. And there is post-op, you still have hemosiderin. So we're just gonna go march up the brainstem, far lateral approach. I used to make big incisions. Now I ended up making very small, linear or slightly S-shaped incisions to get us there. And it really gets us there very nicely. This is a woman from London. She has this cavernous malformation. She's bled a couple of times. She's an editor at the London Times. Here we're cutting the dentate ligament. Here's the lesion. You see how this approach just makes it so easy. You saw the vein that was part of the cavernous malformation, and we're taking it out in front of the medulla. 11th cranial nerve right here. You see the fluorescent colors of the different ages of our hemorrhages. And we get it out. She wrote a book, Sasha did, which is on UK Amazon. And it's well worth reading because I think we frequently forget when we're seeing these complex lesions day in and day out, day in and day out, that there's a person on the other side of our conversation for whom this is an absolutely singularly devastating event. And they're counting on us for empathy. Suboccipital midline, T-lavellar. These are standard approaches. I like the patient supine, standing at the head or sitting at the head and coming in this way. And then naturally anatomy, picking the entry point that is safe, which we've sort of outlined here. But let's go to a couple of cases. This is a classic cavernous malformation, very symptomatic with 6 and 7 palsy. So it was very straightforward to go in and take this lesion out. Of greater interest is one like this here, that's off to the side, had 2 hemorrhages. Here's the most recent hemorrhage, but there is the cavernous malformation. So here we're going through the T-lavellar approach, which is a spectacular approach. I mean, you can really mobilize the entire tonsil and get movement. So here we are, feet are up here, Head is up here, opening, no retractors, fourth ventricle, choroid plexus, just keep opening. I like putting a little bit of soft gel foam into the fourth ventricle so that we don't have any blood draining into the aqueduct. And then we go out to the foramen of Luschka and we just keep opening, pica. We just go out lateral until we see the classic fibers, middle cerebellar peduncle, the floor. Now that is the floor of the foramen of Luschka, as opposed to just a centimeter to the other side where we would have great consequences of making an opening. Here, it's perfectly safe. So with image guidance, we go right in and we take this cavernous malformation out in a piecemeal fashion. Very, very small opening, just high magnification. And then we see the bottom of the bed and there, a little bit of grunge left behind. Retrosigmoid is a workhorse. We used to do a lot of petrosal approaches at the BNI, and they've just fallen to the wayside. So here's a patient with familial cavernous malformations. This one is symptomatic and with progressive weakness, still has hearing on this left side. So with image guidance, the point in teaching that I make is you're not really interested in getting here. You're interested in getting to the middle of this cavernous malformation so that the distance to bring in the remainder of the cavernous malformation is the same. And naturally, knowing that you're at the other end is a nice reassurance. So here we are. Michael already beautifully demonstrated that above the fifth cranial nerve, there is a perfectly safe entry zone into the pons, and that's where we are here. So we're going right down, getting to the cavernous malformation, enlarging our opening, and then this is one with a recent hemorrhage, so you see a lot of relatively recent hemorrhage, and we just keep taking it out and taking it out. I'm thinking it's growing faster than I'm taking it out. At any rate, it comes out very nicely. And this is the cavity. Patient still maintained the left hearing. I want to show this one because the key for me in the posterior fossa is the middle cerebellar peduncle. So we want to go this way, as opposed to the superior cerebellar peduncle, which has grave consequences when you violate it. This one does. Opening the petrosal fissure. Dr. Lawton showed an absolutely beautiful case of this. This is another one. I like keeping the petrosal vein intact all the time because it means you're not over retracting. Notice there are no rigid retractors in here. So all we're doing is following. We're getting to the petrosal fissure, which, depending on the patient, is easier or harder to open, but never easier than the Sylvian fissure in my experience. The cerebellum is more fragile, but it opens up very, very nicely. And then once we see the white fibers of the cerebellar peduncle, we can then make our opening. You can just see stretching, getting to the arachnoid, and then really beginning to see. And we're going right down to the lesion. You can see right where we're going to the lesion. And now we're going to open a small opening and we take it out. And that same as we did on the previous ones. And there's the cavity with some air within it. Love the supratentorial approaches, midline, lateral, transtentorial, way up. It's an incredible avenue to the deep portions of the brain. So classic here, we have a lesion, we have cerebellum, we have temporal lobe, perfectly accessible this way. We're at the top of the head in this particular case. Sinus is here. Again, no retractor, fourth cranial nerve. We see the discoloration. Cavernous malformation is right there. You can see it's really just a straightforward shot. It doesn't mean we're not retracting. I call it dynamic retraction. We're just using the sucker itself as your retractor. And that's all we did, this tiny little opening. And that's where we entered, and that's the empty cavity. How big can a lesion be where we still can get to it through the supracerebellar infertinatorial roles? This is a 67-year-old man. He was previously operated elsewhere through a subtemporal approach. Now much worse, actually not able to ambulate independently, and this is the lesion. Now the first thing we notice is that it extends much higher. So that's a little more difficult. We see the third ventricle being infringed upon. Same small opening. We get down, tentorium is right here, ambient cistern is right here. Now we have to open the tentorium because we need to get up to the level of the foramen of Monro. Remembering that the fourth cranial nerve is in the subarachnoid space, as long as we open without violating the subarachnoid space, we can be sure that we're not hurting anything. Then going through the medial lemniscus, we go right to the cavernous malformation. And there it is. Sharp dissection, bringing the lesion always toward the center, and then removing that component just so we minimize the opening in the midbrain. And always sweeping around it. Yeah, the sucker is being used as the counter traction so that we're not really just pulling on the eloquent tissue. And now that's actually cavernous malformation. The other was just clot. And then going around piecemeal, more and more of it comes out. And I do like these non-stick bipolars that carry my name from Stryker. And again, this time I used a little laser, really sort of gave that up. And here it is post-op. And then 4.5 months later, his neurosurgeon writes to me that he is now able to ambulate independently with much better balance and this follow-up scan. So this is the largest one in that region that I had. This is somebody from Copenhagen, a young 15-year-old, and you can see the lesion and you can see how far it extends up, pushing really the foramen of Monro upwards. Giant. What is the best approach? We decided we'd again use the same orbitozygomatic, cutting the tentorium, just like in the previous case. Again, no rigid retractors. Then opening based on the image guidance, and we get to the cavernous malformation. And then it takes quite a bit of time. We have to cut the pieces to make them small enough so we can bring them out through our opening. Until we're really satisfied, we've done our very best job to get it all out. And so here we are at the end, all the way up there. And here's the post-op. And here she is just before she's leaving. She did very, very well. OZ, another workhorse for the brainstem. When you have a lesion like this here, you can just go lateral to where the motor fibers are, and it comes out very nicely. And this patient had no change in her neurological examination by taking this out. More difficult and more interesting is this patient with 3 bleeds. in the interpeduncular space. How do you get there? Well, you can't really come ipsilateral. There's no way to come from behind. So the contralateral orbitozygomatic approach here is the best. And in this case, the trajectory, here's the optic nerve, the internal carotid artery. The best excuse me, the best direction for approach was really between the optic nerve and the internal carotid artery. Hypophyseal vessels that were separating, and then the interpeduncular vasculature, which is so intrinsic and beautiful, making absolutely sure that image guidance was on target by checking known anatomic sites and correlating it. We get to the cavernous malformation and utilizing, again, those sharp little instruments, my dissectors that we developed with Cogent, we are able to get this lesion out. And again, it's really all a matter of the appropriate approach. And here we are. This is the way we came. You can see the post-op. 33-year-old with this lesion that's been followed for 5 years. His big problem was really the disabling right arm tremor. You look at this lesion where it's sitting, it's hard to come up with a good, easy approach. We decided that the best approach would be through here, through the Sylvian fissure. So Sylvian fissure way up on the middle cerebral artery. So here we are, that's middle cerebral artery. Sylvian fissure has been widely open. Now we're below the middle cerebral artery, just to the side of it. Image guidance directs us right to the cavernous malformation. And through a very small opening, which I assume are optic radiations, although there was no problem with vision post-op, and I'll show you. We get to the lesion, and the vascularity of these lesions varies a great deal. This one was quite bloody. The nice thing about bleeding from cavernous malformations, all it really requires is patience. A little bit of tamponade and patience, no matter how severe. And we get it out piecemeal until we're satisfied that it's all gone. Middle cerebral artery. So you can see where we are in the Sylvian fissure, internal carotid artery, anterior cerebral artery, all the way up here. We left a little blood behind so you could see the cavity. But what we also did is we caught some vessel that I don't remember at what point we did this, but the tremor was completely gone post-operatively. He did have worsening hemiparesis, which completely resolved at 6 months. But his tremor, which was his big problem, was gone. And I suspect that it was not taking this out, but rather the little infarction that we created. Better to be lucky. Trans-Colossal, I've already shown you some cases. I'm just going to show you a couple of deep cases. At the roof of the third ventricle, again, I like horizontal position. We're going across the midline. I like going, after we get into the lateral ventricle, I like going lateral to the choroid plexus. Here's the foramen of Monroe, choroid plexus. And the reason is, then you have the choroid plexus as an extra protection for the fornix. The fornix is right behind the choroid plexus here. So I'm using it as a buffer. And when I enter the third ventricle, I'm looking right at the cavernous malformation. Again, I'm using this was a trial as we were evaluating the CO2 laser. And it was nice here because I'm using it to hold up the choroid plexus and while I resect the rest of the cavernous malformation. But again, you can see the horizontal position, no retractors required, and it comes out. And there's the post-op. This next patient, a little more difficult. This is a young man from Israel with these symptoms. And you can see the cavernous malformation sitting in the very bottom posterior end of the third ventricle, entering the aqueduct. Here it is, third ventricle, aqueduct, end of third ventricle. So we do exactly the same approach. Now we're in the third ventricle. Here I do need a firm retractor to hold over the corpus callosum because it sank into my way. Here's third ventricle, entry, aqueduct, right there. So we can very carefully, circumferentially resect this cavernous malformation. Always gentle counter traction. We're using the lighted sucker that Kojin has made for us until we get it all out. There's the retractor, just to prove that I do use it. Here's the pre, here's the post, pre, post. And the last case I want to show you is, is this one. This is a 6-year-old who had sudden deterioration, hydrocephalus, was operated in his home country for 16 hours with severe blood loss, no diagnosis. He then went to Houston, where they also tried embolizing and surgery and stopped again for extensive blood loss. And I just want to make the point I made before about lesions that are actually inside the vascular sinuses. This is inside the lateral sinus. And these lesions are incredibly vascular. And when they're small and when they're like in the cavernous sinus, the first line of treatment should be gamma knife. So anyway, this is a cavernous malformation. Obviously, Dr. Albuquerque was able to find one little external vessel that they didn't find in Houston and was able to inject all of this onyx into the lesion. And I believe this one is one Mercedes-Benz. This is another Mercedes-Benz, and that's the third Mercedes-Benz. That's how much that costs. First thing I did was make the craniotomy bigger. Then I got to the sinus on one side, cut it, since it obviously had no function whatsoever. Then on the medial side, and then it was nothing to take this out. You can see the sparking of the onyx as we're cutting the cavernous malformation. And really comes out, it's just like an avascular tumor. There's absolutely nothing to it. And there it is. Medial cavernous medial lateral sinus, and then lateral. Here he is, beautiful mother. Here's the post-operative MRI scan. And I was very disappointed that she kissed him instead of me when I had done all the work. This is 1-year follow-up. He was an excellent student, and his athletic abilities even got him a TV appearance in soccer. So this is what it was originally, and this was 9-year follow-up, and that's what it looks like. And he has remained very well. So I just want to show you what we considered were the safe entry zones based on experience. And my apologies go to all those patients that I have hurt by not recognizing where it was safe to enter their cavernous malformation. Our obligation as teachers is to make sure that our students don't repeat the same mistakes we made originally. These are the Brainstem books that really discuss every one of these approaches. The last one with Michael, and I look forward to seeing his cavernous malformation book next. So in conclusion, I think it's perfectly reasonable to resect deep, symptomatic and accessible cavernous malformation. When not to operate is of equal or maybe even greater importance. Image guidance, minimal retraction, review your corridors appropriately appropriate, less or more. That's a teaching point. I emphasize to the residents that when they finished a case, they looked at the operative field and they would evaluate whether they had enough room, so they should have had more, or more likely, there was a lot of exposure that they didn't make, so the next time you can adjust and improve them. So I thank you very much for your attention, and want to compliment Naren for hosting a great series. Thank you.
Professor Spessler, thank you very much for outstanding lecture, plenty of mastering, nuance, plenty of wonderful microsurgery and beautiful anatomical examples. We have many questions from the audience, and I'd like to start with one of the questions from Dr. Walsh. He's wondering about the usefulness of CO2 laser, the real usefulness. Why do you use that?
So we actually published on that when it was developed. It was the beauty of it was that the laser went through a flexible little tube which acted like millions of mirrors. So it would it made the rigid, if you remember the old days, Miguel, the CO2 laser was a bunch of articulated, firm, terrible to use. Everybody had one, and within a couple of years, it all stood in a storage room somewhere. The beauty of this was really that it went through a fiber, so you could use it like a fiber. And I would say it has some use, but after we did the study and we published the study, I used it less and less, and in the end, I didn't lose it at all. I'd be interested to know whether Michael is using it.
Just a second.
Yeah, I can comment. First, Robert, beautiful talk, and I'd love to ask you some things myself. But with regards to the laser, the laser is what I have found is a great cutting device. So if you want to have a really effective cutting tool that's very compact and strong, it's wonderful. But as Robert has shown in all of these beautiful videos, it's really not about cutting these lesions. It's about teasing them away. And so when you come in with a strong force like a laser and start cutting things, really what you're doing is you're hurting your chances of getting it all. You're cutting little bits, and you might not actually be using the tissues in their natural capsules and planes to get all of it. So I too have gone away from it and don't even think about using it now.
Okay, thank you very much. Thank you very much for those answers. We have another question from Dr. Parek. He's asking about the use of ultrasound in spinal cord surgery. Do you use ultrasound for spinal cord removal of tumors?
It's been a very, very long time that I've used ultrasound in the spinal cord, and that is because I think our ability to localize the lesion has become better and better over the years. If there's any doubt, and it'll verify for you the location of the lesion, I would say there's no reason not to use it.
Okay. Thank you. There is another question from Dr. Giant. And you have mentioned something about that, and also Professor Lawton, but he's asking about how much do you rely on intraoperative monitoring for spinal cord surgery and brainstem tumors?
Yeah, it's a very straightforward answer to me. It's sort of like monitoring the heart rate, respiration. If there is a change, I review the operative field to see if I'm compressing something, whether there's something that could explain a change. And I must say, early on when there was a change, like in the motor evoked potential when operating in the spinal cord, I might have stopped the surgery and come back, but found that if the operative field was fine, the monitoring really did not determine post-operative neurological function. So now I use it just simply as review, take a pause, make sure that everything is okay, but then continue.
Thank you. Thank you very much. There is another question from Dr. Gomez regarding neuronavigation, positioning of the patient, and until which extent and how frequently you see some distortion due to the brain shifting, due to CSF release or repositioning of the patient after neuronavigation.
You know, the beauty is that for the brainstem, which is so well tethered by the vascular and neural elements, there's very, very, very little shift that would cause problem. When there is shift, when you're up in the supratentorial space and you've taken out something big, it rarely is a problem because you can see around. But there are already software updates for recalibrating if you really need it. So for me, it has not been a problem with the deep lesions.
Thank you very much. Well, I have a couple of personal questions. One of them is regarding the most appropriate timing for surgery. This is basically, I have my own idea, but basically for the youngest colleagues in the audience, what about the timing for surgery?
Yeah, the simple answer is when they get to the BNI. But,
okay.
But in all seriousness, there are the patients that have malignant bleeds. I remember very well the daughter of an ENT surgeon who was in another state. And I reviewed the films and I said, well, there's no rush. Usually we wait for the hematoma to become liquefied and then we operate. And within days, I mean, during those next few days, she had hemorrhage after hemorrhage after hemorrhage, and she was flown over and had emergency surgery. Those are very uncommon. Most of the time, if you have the option, if I had somebody with a brainstem Cav-mal with a hematoma, and we'd made the decision that it's an operative case, I would sit on it until the blood was likely to be liquefied. And so if you could wait a couple of weeks or 10 days, that would be my druthers. But the bottom line is when they get there.
Okay, thank you. Well, I have a personal nightmare with brainstem cavernoma that is an irregular lesion with very sticky and gliotic plane. That is, in my humble experience, what is just leading you to a very bad result. Have you any tip for that? Any trick?
Well, I'll tell you, I think the edge of the cavernous malformation, which lies in the gliotic plane, is the one that is most critical and that requires the most time to get rid of. So I have very fine forceps, which have a little teeth in it. Again, I had them specially made for this with Cogent. And then that allows you to grab the little tissue, and then your sucker in the other hand, which has a teardrop in it, so that when your finger is not on the teardrop opening, there is serosuction at the end. That is used as the counter pressure. And so it's just this gentle picking up of the edge of the cavernous malformation, the importance of which I did not recognize early. And that's why we had recurrences that shouldn't have happened.
Okay, thank you very much. Very important tip. Another question, how much do you use DTI before surgery for planning or whatever?
Yeah, it was really a neat thing when it first came out, and it sort of reminds me of the first CO2 laser with the articulated arms. You know, the approach is based on anatomy. Obviously, looking at DTI makes sense beforehand, but it hasn't really influenced, in all honesty, the approach to these lesions in my experience.
Thank you very much. Well, we have among us also real giants, and I don't know whether Dr. Cohen-Gadol wants to make any question, and of course, Dr. Lawton and Dr. Mauricio Giacongelli.
Yeah,
please,
I'm going to mention.
Sure,
I'm going to mention Miguel. Miguel, thank you so much for giving me the opportunity. First of all, I have watched this lecture 3 or 4 times, and every time, Dr. Spetzler, I learned something different. it's amazing. The lecture just never gets old, and it becomes more enjoyable every time. I wonder if sort of wine or something you're drinking that with time, it even gets more enjoyable to consume. So two things I wanted to, number one, really spectacular masterpiece, no question, the techniques you have devised for these lesions. Number two is that I've learned so much from you and the use of the mouthpiece. It's so incredible, indispensable in these lesions. You've got to free your hands. You've got to make the microscope part of your face. And that's a critical component of a retractorless surgery. The fact that these surgeries look so incredibly beautiful that you see in these videos is that the microscope has really become almost like a pair of glasses. At any moment, you can adjust it, keep the scene under focus without necessarily exposing more than you need. And that principle takes a long time to learn and has a steep learning curve. And number two, very well mentioned in his lecture, is that I try to avoid the floor of the fourth ventricle as much as possible. Unless the lesion is really exophytic, absolutely distorted and has come out of the floor of the fourth, I take the middle cerebellar peduncle approach through the transpetrosal fissure dissection. And I actually go through 2 or 3 times longer path of normal middle cerebral peduncle to get to the lesion along the floor of the fourth ventricle and have much less morbidity. And I think that's something that as I have done more and more, I become more and more fond of going through the middle cerebral peduncle and at all costs avoiding the floor of the fourth ventricle. Dr. Spetzler, do you have any thoughts you want to share in that regard, please?
You know, Aaron, I have stopped talking about the mouthpiece because it has been so incredibly frustrating to me that this has not been universally accepted by the neurosurgical community.
I agree.
And the problem is really in the programs. I don't know of any resident or fellow that's come through that wouldn't try very, very hard to get the mouthpiece on their microscope. For me, even at the CNS on the podium, when I did some anatomical dissections for the audience, I needed the mouthpiece because it's part of me. You are absolutely, and I really miss the fact that retractorless surgery is really only possible because of the mouthpiece, because you're constantly shifting around. Very, very good point. The reason that you learn something new every time you listen to this presentation, Aaron, is because you're just a very, very slow learner. Very good point. Thank you.
Thank you very much. We also have Professor De Pujari, my good friend. Do you want to make any comment or any question to Professor Spetzler?
I think we have learned quite a few things. The lateral supracerebellar approach is something which we have learned for this, and we're thankful for various tips as you always get. Many of us are slow learners, so you have to bear with them.
Okay.
Thank you.
Can I ask Dr. Lawton, do you have any questions for Dr. Spetzler?
Yeah, Robert, great talk as always. I am just curious, your patient from Copenhagen, that case that you showed, the supracerebellar one, it's always fun to look at these again and again. And, you know, now in the perspective of this taxonomy that we've been trying to create here, it's intriguing to me because it works so well when you have a lesion that's clean and fits within the boundaries. But there's going to be a fair number of these that are what I would call mixed, where they're actually in 2 of those little boundaries. And when you get one of those, like the Copenhagen patient, you could make a strong case for what you did, which is the lateral supracerebellar. You could also make a strong case for a trans-colossal, trans-choroidal approach from above. And you could even make a case for an interpeduncular transsylvian approach from, an orbitozygomatic route. And I'm just curious how we get over this problem of the mixed lesion where you have a conundrum where you could make strong arguments for different approaches. And, like in your case, it seems to have boiled down to preference and comfort level. You at the end of your career really loved that approach and pushed it in ways that I don't feel quite as comfortable pushing it. Like if I push that approach up to the foramen Monroe, that makes me really uncomfortable. And other people, you know, might have a similar bias for a different direction. I just wonder if you have a thought about that mixed lesion where you have multiple avenues.
Yeah, I think that's really a good point. And in the beginning of my presentation, I try to sort of point out the decision-making process, the thought process that goes into why you choose what you do. But you are right. I absolutely loved the supracerebellar infertinatorial approach because of its incredible versatility. And the fact that you can take out medial temporal lesions through that same approach, and by cutting the tent more, you can go all the way up to the foramen of Monroe. If I had that same lesion today, even though I recognize that the 3 routes that you supplied are, depending on whose hands they are in, I'm sure equally effective, I still would pick that one just because the patients have tolerated transgression of the midbrain at that level so well. But it's up to you to figure out the rest.
Okay. Well, I think we are just finishing this part of the symposium. Before handing over the moderation to Naren, I don't know whether there is another last question for Professor Spetzler.
Thanks. Thank you very much, Professor Miguel Ares. I think I'm keen to ask other senior consultants here whether they have any questions. Mr. Josh Patel, do you have any questions for Mr. Spetzler, please?
Well, actually, rather than a question, I think what I want to say is this. When I studied anatomy, and this is a long, long time ago, the brainstem was fascinating, and I was fascinated by coma. And as I started neurosurgery, the one place I thought the brainstem was going to be a forbidden place. And I think when I started understanding cavernomas, and I saw Professor Spetzler operate on these, and I started looking really hard into the skull and anatomy, I think what it taught us, these brainstem cavernomas, is brought us all together, I think, to find avenues to try and get to these. And I think what I want to ask Professor Spetzler is, when you look back in your career, what do you think in neurovascular surgery has really changed? I mean, in Oxford, of course, we've got ISET, and that changed neurovascular surgery with coiling versus clipping, as you know. But what do you think has really made the differences in terms of maybe cavernomas, AVMs, and aneurysms? I'm sorry to ask about a general question rather than just purely cavernomas.
Yeah. I think we'd be here for a couple more hours, but succinctly, I think the big changes have been in imaging. I mean, for example, ICG green, the introduction of being able to see the vascular in the operating room. It has to do with endovascular advances, which have been just phenomenal during my career. It has been understanding the ability of what radial surgery can really do, remains still controversial in many individual cases. And I think this particular presentation today, the whole topic of cavernous malformations, has taught us more about what is possible as far as resectability is concerned in the brain than any other lesion.
Thank you. Dr. Boop, do you have any questions for Dr. Spetzler? I think this is quite a unique time that we have got so many senior people at this place.
No, I would just like to thank him for his comments on retractorless surgery. I think positioning and staying away from fixed retractors has been another major advance in the last 10 years. I appreciate that.
Thank you. Thank you very much. Thank you very much, Dr. Boop. Before I thank Dr. Spetzler and Dr. Lawton, I just want to, first of all, not to forget that I have to thank Dana and Marinella, who have been very helpful for me to liaise with Dr. Spetzler and Dr. Michael Lawton. And I know that if I need next time to bring them here again, I know who I will talk to. So please do say thank you to them. And Professor Spetzler, this is your 4th lecture that you have given us to the Listserv, and really appreciate that you take the time, for each of us and each of our lectures and the cases that you have discussed in the Listserv. We are very grateful. Thank you very much, sir. So now I'm going to ask Professor Maurizio Iconangeli from Ancona to give the closing remarks to summarize what we have learned and what's. Thank you, Professor Iconangeli.
Hi, Naren. Hi, everyone. Thank you, Naren. And I take some note, much note. But my duty is quite easy because this webinar was really very exhaustive, rigorous, and updated. So for me to wrap up a little bit, the conclusion is easy. The only stuff that is still quite controversial and not well understood by the student or the resident, or even for us as a neurosurgeon, is that I learned that the cavernous malformation are unique for that patient and a dynamic disease. So this has a little bit of confusion, because this is add a new factor to all the other factors that we have to consider in our decision-making process. So this is something to reflect. The key question is, of course, especially in the eloquent area or in the brainstem, as Dr. Lawton said, is the main question is resected or observed. And this is an hard decision, because if a Greek neurosurgeon, as Professor Spetzler is, said that when not operate is as important is when operate. So as this is the same, and is always is just stated that in brainstem lesion, he recommended 46% of the patient not to operate. This is an hard decision for a Greek neurosurgeon. So this is something that that we have to consider. Operate and not operate is equally important, is as important as operate. And another factor that I want to stress is that radiosurgery can be ineffective and modify the cavernoma. That is already a dynamic disease. And that, of course, in surgery, the exposure is everything, and take the advantage of the gravity. The other factor to consider is that, of course, the location, the prior bleeding. I was thinking that after the first bleeding, surgery must be considering very as important. Now, today, we learned that even you can even not operate after the first bleeding, but of course considering the operation for sure after a second bleeding. This is something that still is confusing, because after the first bleeding we have to consider the surgery. And another factor to control other than bleeding is the seizure control. Only Dr. Monaco stressed this aspect, because even the drug-resistant epilepsies can be an indication for surgery. And in case of multiple lesions, still there is a high space for treatment, mainly surgical or combined surgical or surgery, because in multiple lesion there must be some active lesions. So multiple lesion, even in case of multiple lesion, treatment must be considered. And there is not competition between surgery and radiosurgery. As stated in schwannomas or meningioma, they can be treatment that in some case can be combined, or with a really multidisciplinary discussion, we can select the best approach without any barrier, any real ego. And but one big factor against that was already well stressed against the radiosurgery. Of course, we are surgeon. We have I would say a vision toward surgery, but this is true that radiosurgery has a latency of around 2 years. So a lesion that already bled, this is a factor to consider. And we have we have had some suggestion that we need some factor to predict how is the natural history of that lesion, because this is the key concept in deciding the treatment. And Dr. Patel provided us a sort of radiological classification. Professor Lawton, a taxonomy. And with these two topic and all the other factors, the age, the location, maybe we can construct our meaning, our decision meaning. And Chandra said, stressed the concept that perhaps is not necessary to remove all the hemosiderin ring. And I think that these are the key concept that I want to stress. So we are surgeons. We have to consider surgery. Surgery must be proposed, but we have to consider how that specific lesion in that specific patient can evolve in the future. Thank you, and thank you, Naren.
Thank you very much, Professor Aikananjali. That's a fantastic summary. And a couple of housekeeping messages before I thank all the speakers and participants. I put the link for the YouTube channel where the recording is on the chat box. I will also tomorrow morning send you the link for the Zoom server where all the lectures are. I think that, I can't imagine me spending hours and hours and weekends going through these lectures. I think, as Dr. Cohen said, the more time you see it, more you learn for mortals like us. And so please use the links, and I will also then try to make the videos each single as well. So this leaves just me to say thank you very much to all our eminent speakers, and I have to thank Mr. Jash Patel for encouraging me to hold this. I'm in Oxford. I joined there in December. Thank you very much, Mr. Patel. And thank you very much for all the eminent speakers on this Saturday. And Dr. Spetzler Dr. Booth have been here, as well as every senior surgeon from the morning. So, and tomorrow we are having another very complex area that we are having a webinar on slit ventricular syndrome. And once again, the star would be again a former colleague of Dr. Switzerland, Dr. Lawton, Dr. Rickett. He will start off with the classifications. So I hope I will see many of you, and look forward to you all joining us on another webinar, and certainly we'll have another repeat Cavernoma in 2 years' time. Thank you very much, and wishing you a lovely evening and a weekend. Bye for now. Cheers.
Thank you.
Thank you.
Thank you.